session first. So, on behalf of the committee, I would like to welcome Minister for State Jim Daly, who's standing in for Minister Harris in view of the extraordinary cabinet meeting that's been held this morning. So, thank you very much, Minister, for standing in. We also welcome the Interim Director General of the HSE, Mr. John Connaughton, who is accompanied by Anne O'Connor, Deputy Director General and Chief Operations Officer, Mr. Stephen Mulvaney, Deputy Director General and Chief Financial Officer, Mr. Damien McCallion, National Director Screening Services, and Dr. Colm Henry. I may have left out one or two people, but you're all welcome. Oh, excuse me. Secretary General of the Department of Health, Jim Breslin. Jim. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements that you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside the Houses or an official, either by name or in such a way as to make him or her identifiable. Could I now ask Minister Daly to make your opening statement, please? Thank you.
Margaret, and just like to acknowledge the invitation to Minister Harris and myself and the other Ministers of State to attend here today, and to acknowledge, as you did, Chair, the presence of Jim Breslin, the Secretary General, and also I'd like to welcome John Connaughton, Acting Director General of the HSE, and indeed the accompanying HSE officials who are with us today. The invite here today was to give an update on issues affecting the Department of Health and the HSE, including expenditure to date on Vote 38. I am happy to do so, and I will also outline priorities, significant development and progress in the area of health. I will start off by updating on the vote position for 2018. As you will be aware, the Government approved gross expenditure of just over £15.3 billion for the health services for 2018. The announcement by my colleague Minister Donnelly that he intends to allocate an additional £700 million to the health service in 2018 by way of a supplementary estimate is most welcome, as is the fact that it has been possible to carry this additionality into the base for 2019. Consideration of the supplementary estimates will be before this committee very shortly, so there will be an opportunity to go into further detail. The gross current budget for the health sector for 2019 is £16.36 billion. This is equivalent to an increase of £1,521 million or 10.2% compared to the 2018 original allocation of £14,839 million. I'm also pleased to announce a capital budget of £667 million, which is an increase of £174 million on last year's capital budget. This brings the total gross health budget for 2019 to over £17 billion. For the immediate future, the next significant step is agreement of the National Service Plan. The Service Plan 2019 will set out the type and volume of services that the HSE will provide in respect of the significant budget of over £16 billion it has received for next year. The HSE must ensure that the most beneficial, effective and efficient use of resources is made when planning the services to be provided in 2019. On Budget Day, Minister Harris said that we are now firmly in the era of sláinte care, and 2019 will see the HSE National Service Plan based and developed for the first time on the framework of the sláinte care implementation strategy, which sets out the Government's plan for delivering high-quality, sustainable and equitable health and social care service over the next decade. The National Service Plan will set out the details on how the totality of health service resources will be made to advance sláinte care objectives. The HSE is now in discussion with the Department on developing the service plan for 2019 with the goal of delivering a plan which makes progress in meeting priority health and social care needs and clearly allows the Executive to operate within its notified resources. I expect to receive a draft service plan submitted for the approval of Minister Harris from the HSE in the coming weeks. The focus on sláinte care in this process is an important element of the strategic transformation of our health service, but of course we must also focus on the here and now and the immediate challenges we face. As we head into a period of pressure on our health service, I want to acknowledge the ongoing commitment, dedication and cooperation of people working in our health services. This is something Minister Harris and we in Ireland can be very proud of. I know that on a daily basis our doctors, our nurses, our healthcare professionals make personal sacrifices in the interest of putting patients first. However, we have learned lessons from previous winter seasons. Consideration of staff management issues is just one element of a planning process to ensure that we prepare for the winter period in the best way we can. My department is working closely with the HSE to ensure the most effective response to this winter within current capacity and resources. €10 million in additional funding has been allocated in 2018 primarily for the provision of supports to get patients home from hospital where appropriate before the end of the year, with a focus on supporting patients in the over 75 age group. The core objective of this measure is to ease congestion in hospitals as far as possible before the end of the year to prepare for the expected peak in demand in the new year. In addition, Mr Harris has requested in the context of the National Service Plan that HSE plan activity in 2019 to manage critical demand pressures, most particularly in respect of increased attendance at emergency departments. This planning will include activity in hospitals, primary care and community care to ensure that the system is working at full capacity throughout busy periods. This request provides clarity to the HSE on the level of funding available in 2019 to meet winter pressures. The challenges evident in hospital emergency departments are the symptom of broader challenges both within the hospital itself and across the wider health service, increasing capacity and efficiency throughout the hospital, improving services in the community to provide care for patients outside of the emergency departments, and supporting the discharge of patients home or into the other community services are all part of the solution. The National Development Plan provides for a major increase of 2,600 in bed capacity as identified in the Health Service Capacity Review, and this will remain a priority in 2019. Over the past 12 months, an additional 240 beds have been opened, and a further 79 additional beds are planned for Q4 2018 and early 2019. A further €10 million will be invested next year to enable additional beds to be opened to alleviate pressure on emergency departments for winter 2019-20 and the years ahead on foot of the recommendations in the Health Service Capacity Review. The Department is currently in discussion with the HSE in the context of the National Service Plan 2019 to identify the sites for investment and the associated number of beds as part of an agreed capacity programme for 2019. Increasing capacity and access goes hand in hand with reducing waiting lists. A very significant investment of €55 million was made in the NTPF this year, and ambitious targets were set to reduce the number of patients waiting for a hospital procedure to below 70,000. I am pleased to report that as a result of the activity of the HSE and the NTPF, we are on track to meet this target, with the number of patients for the end of October at 72,000, down from a peak of just over 86,000 in July 2017. The improvement has been delivered against a backdrop of increased demand for services and also a very challenging start to the year that saw elective activity curtailed as a result of emergency department pressures and severe weather events. Building on this progress in Budget 2019, the Government has further increased investment in this area, with funding to the NTPF rising to €75 million in 2019. The NTPF plans to further reduce the number of patients waiting to below 59,000 by year-end. While significant progress has been made on inpatient and day case procedures, the number of patients waiting for their first outpatient appointment continues to be a challenge. Minister Harris has asked the HSE and the NTPF to bring a renewed focus to outpatient activity in 2019. Arising from the increased investment, the NTPF plans to arrange at least 40,000 first outpatient appointments in 2019. Earlier this year, Minister Harris approved the establishment of a central waiting list validation function within the National Treatment Purchase Fund. Validation has many benefits, including the identification of patients on waiting lists who are ready, willing and available to proceed with hospital care, the reduction in the did not attend rate and an improvement in information for managing waiting lists. It is worth noting that over 500,000 patients do not attend their appointment each year. Validation has been underway for a number of years at a local level, and the NTPF estimates that over 30,000 patients who no longer require an outpatient appointment will come off the outpatient waiting list as a result of this activity next year. I wish to now update members on matters related to cervical check. Dr Gabriel Scally provided a final report, as the committee will be aware, of his scoping inquiry into issues relating to cervical check in September. His report provided welcome reassurance about the laboratories currently contracted by cervical check. He is satisfied with the quality management processes in these labs. It is very important to say that Dr Scally confirmed that he found no reason why the existing contracts for laboratory services should not continue until the new HPV regime is introduced. He also stated that continuation of screening in the coming months is of crucial importance. The Government fully agrees with this. Screening saves lives. Cervical check has been successful in reducing cervical cancer rates in Ireland. As stated in the Scally report, the lifetime risk of a woman getting cervical cancer was 1 in 135 in 2015, significantly lower than the lifetime risk in 2007 of 1 in 96. This represents a substantial improvement. Government has accepted all 50 of Dr. Scally's recommendations. Minister Harris has committed to returning to Government within 3 months, as recommended by Dr. Scally, with a full plan for the implementation of these recommendations. In June 2018, Minister Harris established the National Cervical Steering Committee that is co-chaired by the Chief Medical Officer and the Assistant Secretary for Acute Hospitals in the Department, and includes senior management of the Department, the HSE, clinicians and patient advocates. It provides oversight and assurance in relation to managing the response to the cervical check issues and ensuring the implementation of the key decisions taken by Government. The minutes and agenda for each meeting are published on the Department's website to allow for full transparency and for members of the public to be updated on the Committee's activities. I am updated weekly, receiving updates on the progress of the Steering Committee, and these are also published. The Committee has had 12 meetings to date since it was established on the 21st of June last. The most recent meeting was on the 8th of November. The Committee will meet twice more before the end of this year. Separate to the work carried out by Dr. Scally, the independent clinical expert panel review, which is being led by the Royal College of Obstetricians and Gynaecologists, is underway. This review is examining the results of screening tests of all women who have developed cervical cancer who participated in the screening programme since it was established. The review will provide independent clinical assurance to women about the timing of their diagnosis and any issues relating to their treatment and outcome. Minister Harris would also like to take this opportunity to thank the Committee for their time and engagement in recent days as he discussed the Health Regulation of Termination of Pregnancy Bill 2018. In addition, preparations are ongoing for the implementation of the service as soon as possible. The Department and the HSE are at an advanced stage of drafting contractual proposals for the provision of termination of pregnancy services in the community setting. In parallel with service planning and expansion, clinical guidelines for medical practitioners are in preparation by the medical colleges, and the Department has provided a grant to support their development. Mr Harris is conscious that women are continuing to travel every day to access services abroad and in some cases to order medication over the internet. So he wants to stress again that it is this Government's priority to have a medically delivered, safe and regulated service for the termination of pregnancy for all those who require it, based on the huge mandate that the Irish people have given for this work. There is also significant work being done to implement the National Maternity Strategy. Ireland's National Maternity Strategy was published in 2016. The National Women and Infants Health Programme has been established within the HSE and is driving the strategy's implementation. A key aim of the strategy is to ensure that appropriate care pathways are in place so that mothers, babies and families get the right care at the right time by the right team and in the right place. The strategy's 3 care pathways, supported, assisted and specialised, will deliver maternity care in a manner that is both appropriate and women-centred. A detailed implementation plan for the strategy was published in October 2017, providing a clear roadmap for the development of maternity services into the future, and in 2018 the Government provided additional development funding of €4.55 million to progress the strategy and to improve waiting times for gynaecology services. The National Women and Infants Health Programme highlighted a number of priorities which this funding has continued to address over the course of 2018. These include the development of community midwifery teams, the development of quality and safety frameworks and the improvement of access to anomaly scanning services. 2018 has seen the continued expansion of anomaly scanning services in maternity hospitals and units across the country and the development of critical quality and safety initiatives. The development of the supported care pathway and of community midwifery teams to deliver care in line with the recommendations of the strategy is also ongoing, and a multidisciplinary steering group has been established by the NWIHP to oversee the implementation of the strategy's model of care. This year has also seen the continued rollout of the very successful maternal and newborn clinical management system, which phase 1 completed and implemented across 4 sites: Cork University Maternity Hospital, University Hospital Kerry, the Rotunda and the National Maternity Hospital. Looking ahead, it is important to ensure that we build on developments to date, and the Department will be engaging closely with the programme to ensure this progress continues into the coming year. So to conclude, Cathaoirleach, planning for the weeks and months ahead, now we are in the winter period, is of course the top priority. Yes, we face challenges. However, we now have a long-term plan for healthcare, and as Minister Harris has just outlined, we are making progress this year, and we will each and every year. Thank you again for the opportunity to brief you on developments. I'm interested in hearing your views and look forward to your questions. Margaret,
Thank you very much, Minister Daly. And now to ask John Connaughton to make your opening statement on behalf of the HSE. Thank you.
Well, good morning, Chairman, members of the committee, and thank you for the invitation to attend the meeting. I'm joined by my colleagues, as previously introduced by the Chair. In preparation for the meeting, committee members requested information and replies to a number of specific questions, and you will by now have received a written response to them. I will therefore confine my opening remarks to the following issues. Firstly, can I welcome the announcement by Minister Donnelly that it is intended to allocate an additional £700 million to the health service in 2018 by way of supplementary estimates, which now brings the 2018 net revenue budget of the HSE to £15.2 billion. I know that this was the subject of the Joint Committee on Health meeting of the 24th of October, so I will confine my remarks to welcoming the fact that this will be included in the base funding of 2019. The HSE is currently finalising an implementation delivery plan in response to the Scally review recommendations. This is a considerable piece of work ranging from procurement to open disclosure and from governance to risk management. While our focus will be on early implementation, our concern will also be to ensure that plans are solid and sustainable in the future. We are continuing to support the international experts' ARCOG review, which was commissioned by the Minister for Women who were diagnosed with cervical cancer. This work will continue through 2018 and into 2019. A key risk to enable cervical screening to continue in Ireland was the extension of the laboratory contracts. We have secured agreements to enable continuity of the service and are currently finalising contracts with service providers. The new model will ultimately see a more balanced model of public-private provision in Ireland. We are also carrying out extensive worldwide exercise to secure additional capacity given current demands leading to extended reporting time for women. We are also progressing plans to introduce primary HPV screening with a focus on international best practice to ensure we have a successful deployment. At the present moment, until we complete our planning work and finalise the current laboratory provision, we are not in a position to provide a critical path and timetable for the introduction of HPV testing. We are continuing to provide support to women and their families impacted by the crisis. We are also strengthening the role of patients in the programme with the establishment of a public patient involvement panel and patient representation on key groups. Turning now to other matters, can I advise the Committee that planning for winter 2018-19 is well advanced in respect of the planning and escalation, the operational management of patient flow and maintaining public health in place at hospital group and CHO level. There are 5 priorities for this winter in the following broad categories. 1. Ensuring integrated working between acute hospitals and the community. 2. Ensuring robust preparedness plans that optimise their existing resource. 3. Ensuring de-escalation pre-Christmas, maintaining demand and capacity balance between Christmas and New Year, and ensuring the provision of enhanced measures for the New Year's surge. 4. A focus on ambulatory patients and on older persons, with emphasis on admission avoidance, enablement and community supports. And 5th, strengthened working arrangements with the GPs, nursing homes and the HSE, and clearly we can provide more detail on this as we go through the committee. We are grateful for £10 million once-off funding allocated by the Department of Health for winter. It is intended to utilise this additional funding to increase the provision of community supports pre-Christmas and open additional capacity in January. Since the last Joint Health Committee update, we have made some progress in key performance indicators such as trolley count, with each month since the end of Q1 2018 recording a decrease over the same period in 2017. Inpatient and day case waiting lists have decreased by over 5,000, from 78,000 in June to 72,700 in September 2018, and that is down from a peak of a year ago from 86,000. In the National Ambulance Service, incidents responded to by patient-carrying vehicles in 18 minutes and 59 seconds or less is above target at 81%, noting a performance improvement month on month in the last quarter. And in relation to our community services, HICWA has advised the HSE that all 1,149 disability centres are now registered as of 31st of October 2018 under the national standards for residential services for children and adults with disabilities. This has been a substantial achievement for the sector. It's a very positive indication regarding our investment in quality improvement through dedicated professional programmes and additional financial resources for providers. However, notwithstanding all of the above, we still have significant pressure on acute, community and social care services. There are too many people waiting on outpatient waiting lists. There is also a significant increase in the numbers of people attending emergency departments and increasing unmet demand for home care support, with over 6,000 people now waiting for home support across the 9 community healthcare organisations. All of these are currently the subject of detailed planning in our National Service Plan for 2019. As we move into 2019, we also need to prepare for the introduction of a board to the HSE. This is a welcome and necessary step for the appropriate governance of the largest organisation in Ireland, and I would particularly like to welcome Kieran Devan to the post of chairman. I know from my very early discussions with Mr Devan that a focus on patient safety and quality and culture and values will be early agenda items for the board. The consideration of how the HSE responds to the recommendations on audit, risk, governance and accountability arising from Scarlet reports will also be some of the most important aspects of the early work of the board. Before I conclude this opening statement, Mr Chairman, can I take the opportunity to look forward into 2019 to highlight some of the other key strategic objectives for HSE. Slontacare has provided a framework within which the HSE will focus on transforming healthcare services over the coming decade. New services will be progressed in line with government policy. Care closer to home will be improved by further investment in primary care services through GP services, extension of eligibility, reduction in prescription charges and drug payment scheme limits. There are a number of key organisational objectives that the HSE will also focus on in 2019. These include the designation of the major trauma centre and trauma units in Dublin, commencement of the 9 learning sites focused on a new network operating model for community health networks that will lead to full-scale national implementation, and further development of maternity services and continued investment in e-health with specific regard to the electronic health records. This concludes my opening statement, and together with my colleagues will endeavour to answer any questions that you may have.
Thank you, Mr Connaughton. Now we are going to commence our engagement with our health spokespeople. So first is Deputy Stephen Donnelly, and the proposal is that we would have a 10-minute engagement and then move on to the next speaker. So if you could keep your questions to that time limit, we would appreciate it.
Second round, Chair.
Yes. Deputy Donnelly, thank you.
Thank you all very much, Minister and officials, for your time today and for coming in and for the statements. Minister, I'd like to start with performance and accountability. So we in Ireland spend more on healthcare than almost any other country on earth. The budgets over the last number of years have been the highest budgets ever in our history. The overruns commensurate are the biggest overruns we've ever had. And at the same time, we have more people waiting on trolleys than ever before. The waiting lists in total, whilst there are some improvements in some areas, that the total number of men, women and children waiting is higher than it's ever been. We have children waiting 3.5 years, children with special needs, to get help, which is depriving them of the future they could have and all of their opportunities. We have chronic waiting lists in multiple surgeries. Surgeries this morning will have been cancelled all over the country because our hospitals are overcrowded. It's accepted that a safe and good level to have our hospitals at is about 85%. Our hospitals are between 97 and 104%. Certain specialties are in particular problem. Children with scoliosis, for example, are waiting more than 3 years for operations in Crumlin. As a result, they're having their internal organs crushed by their rib cages while their spines curve to over 100 degrees. Routine appointments at St James's, for example, urology is now a waiting list of over 6 years. As you know well, many of our mental health services have become so fractured that people around Ireland, particularly in terms of child and adolescent mental health, are terrified of being referred from early intervention to CAMS because they're saying the services as good as don't exist. Government figures released under PQ recently said about 1/10 of the staff we need in mental health actually exist. Diagnostics are being cut off for GPs. So I had a letter this week in from Navan Hospital saying that due to a shortage of radiology, radiographers, GPs can no longer refer for DEXA scanning. And the list goes on and on and on and on and on. So in spite of the best efforts of many doctors and nurses, and I'm sure officials, and in spite of spending more money than ever before, and now for many years in a row, many parts of the system are in crisis, and there is a level of suffering and a lack of access that we've never seen before. So, given all of that, my question goes to accountability. Do you know if anyone, given all of this, has lost their job at a political level, within the department, anywhere across the HSE? Has anyone actually been fired for the catastrophic failures that we're seeing across the system in spite of the vast amounts of money being spent?
Minister.
Okay, thank you very much, Deputy. And yeah, I suppose your Your diagnosis, for want of a more appropriate term, I couldn't agree more with, and I think everybody around this room at both sides of the House today accept the difficulties, the challenges, the waiting lists, the unacceptable delays, the difficulties, you know, all of that on the frontline services. So it's a case of what are we going to do about it and how are we going to approach it. There isn't a quick fix answer.
And I'm sorry to cut across you, Minister.
Yeah.
I'm not. My question is not what are your solutions. My question is, given what we both agree is happening, has anyone been fired?
Okay. Can I just to finish addressing the point you were making, because you did make a point about, you know, all of those difficulties and challenges or whatever. Just to make the point that we have, it probably is too late, but I mean the overall slant care, at least there's a direction there, there's a focus, there's an investment, and I think this year more than ever, the alignment with that slant care, you can see it, and into 2019, as the service plan is being developed, there is more and more emphasis on lowering the level of you mentioned scoliosis, things like that, lowering the level of intervention, bringing services closer to home and all of that. To answer your question about accountability, and you know, I'm going to pass it to the HC obviously in a minute, because that's directly, I mean, it isn't the Minister's gift to fire anybody. I think that was a point that was made to one of my predecessors previously by the head of the HSE. It's not a hiring and firing role for any minister to comment on. So accountability within the HSE, I presume I can pass on to the Director General there to answer that specific question, unless you have a specific question for me.
The question, and thank you for your answer. The question is, to the best of your knowledge as Minister, and you are standing in for the Cabinet Minister here, to the best of your knowledge, has anyone been fired over the catastrophic failures that we're seeing right across the system?
Okay. Well, I mean, I don't have the figures to me there, but I'll ask the Director General to answer that about the number. Are you talking about in the past year?
In the past year, 2 years, 3 years?
Yeah, because there's an add-on to your question about the catastrophic failures, which probably makes it more difficult. I can give you a de facto answer whether people have been dismissed from the service in the past 12 months. The reason for that is going to be multifold and unique and individual or whatever. We cannot say that these people were dismissed because of catastrophic failures. But I can certainly answer, or ask the Director General to answer the question about the number of people who've been dismissed from the service in the past 12 months, is it?
Whichever it is, has anyone, due to the catastrophic failures and the pain and suffering being felt across the system, has anyone been fired? Straight question.
Okay. Maybe a straight answer for that, and I can maybe only answer for the period that I've been in as Interim Director General, which is for, let's say, for the last 6 months. Okay. I'm not aware at corporate level of anyone actually being through the disciplinary process for poor performance in that respect. Okay, we do have people leaving the service. Okay, through our disciplinary procedures. Okay, those are a matter for local managers and local staff in terms of what that's about, and I don't think I should be at liberty to actually reveal any of that today. Okay, I do recognise the situation that the Deputy paints. As we go forward, we need to build into the HSE something better around personal accountability. And if I can take a minute, I might want to just say a little bit about what the plans might be around that for 2019.
If we could do that afterwards, Chair, and I'm not, it's not to cut you off, it's just we have very little time. So I'd be very happy to go into that later. But if the answer is no, I think is what I'm hearing. Is that fair? I don't want to put words in your mouth. The answer is no. Okay, could I just ask Minister at a political level to reflect on that? Given what is happening in the system, it doesn't surprise me that the answer is no. But I think it's something that needs to be reflected on. Could I ask the same question? Have any formal sanctions of any kind been taken against anyone for the catastrophic failures we're seeing across the system?
Well, I mean, I can't answer from the system itself, from the HSE, from within the HSE. That's going to be a question I'm going to have to direct to the HSE. Okay,
well, I guess sanctions. The question.
But your question very specifically is for catastrophic failures. That's what you're talking about. Has anybody been dismissed for catastrophic failures?
For the failures we're seeing across the system.
Yeah, and the answer to that is no. There hasn't been anybody dismissed. To my knowledge, there hasn't been anybody dismissed because of what you've outlined there, a litany of what you term catastrophic failures. My answer to that is no.
And Minister, to the best of your knowledge, has anyone been sanctioned in any way?
Again, are you asking for the catastrophic failures that you've just outlined there?
For any of the issues,
or are you asking for, individual misdemeanours?
Yeah, no, absolutely. No, not for individual things. For the list of issues that I've raised, has anyone ever been sanctioned in any way for any of them? To the best of your knowledge?
No, certainly not. Certainly not. I don't know who would be responsible for the entire list of issues that you've raised there that could be potentially sanctioned.
Yeah, okay, thank you.
Other than
Minister
maybe
Conaghan, or Mr. Conaghan, I beg your pardon.
Can I perhaps change the use of the term sanction to escalation? Okay, I think it's the same thing.
Okay.
Where we are. Okay, we have a number of services in escalation. Now, rarely is one service provided and solely delivered by one person. Okay, you can understand that the delivery of healthcare these days is on a team basis, okay, an organisational basis, and indeed across organisations. So we do have a number of services in escalation, and if you want to, we can provide details of what they are, when they were escalated, and what's been happening.
And are individuals sanctioned? So I understand that you might point to as something and say, child and adolescent mental health is in crisis, it needs to be escalated, or scoliosis needs to be escalated, or many things need to be escalated. My question is around personal accountability for what patients are dealing with. Do you know, to the best of your knowledge, has any individual been sanctioned in any way for any of the issues we've raised?
So to the extent that a service is led by somebody, they will be part of that escalation process in terms of determining how we can improve that process. Okay?
I'm asking a different question. I appreciate you're saying that you're looking at issues and trying to solve them. I'm asking, has any individual received sanctions for any of the failures I've listed?
I think it's the same answer as I've provided the Deputy before. I'm not aware of any, but I would say that in terms of the provision of services, you need to think about the entirety of the service and the fact that it's a team-based approach. Okay? But I'm happy maybe to get in a bit more detail about plans for 2019 in that respect.
Maybe later if we could. Thank you. Do I have time for another question, Chair? It's a long question. Will I wait and come back? The next question is going to take more than 60 seconds. I'm happy to stop and come back if
that's okay.
Yeah,
we'll do
fine.
that. Yeah.
Thank you.
Deputy Louise O'Reilly.
Thanks, Chair. Thanks very much. And I don't mean this in a disrespectful way at all to Minister Daly, and I absolutely thank you for coming. It's regrettable that the Minister is not here. I think it's a long time since we've had a quarterly meeting, and we're hoping to be able to rectify that. I fully understand the reason why he's not here this morning, but it is regrettable. But I do thank Minister Daly for being here. So, and obviously everybody else. The recent comments by Taoiseach with regard to annual leave and the difficulties that creates, or the difficulties he alleges it creates, particularly around Christmas time. You just might, because the Taoiseach made that statement, it was grossly offensive, obviously, to men and women, a lot of whom will work hard right over the Christmas period. But I'm just wondering where from that assertion came. Do you count that? Do you have a particular problem in January? Is it counted? How is it accounted for, and perhaps you might be able to shed some light as to why the Taoiseach had said that. I did hear a radio DJ say that he went into a hospital at Christmas and he formed the opinion that there wasn't much going on. I don't think that's the truth. I actually think a lot goes on over Christmas, but perhaps you can enlighten us as to that. With regard to recruitment and retention, it's my understanding that we now have 259 fewer staff nurses than we had in December 17. I have spoken to nurses and they're telling me that it is slow to recruit. In fact, the term that they used was that it's acting as an effective moratorium, the manner in which the recruitment is taking place, because it takes so long from the decision to recruit to actually finding yourself on the ward. So is that in any way analysed? Is anyone looking at that? And can you give us an estimation of where you think the blockages are, how they are manifesting themselves, and if there is any plans to tackle those? Maybe you might share with us what they are. The winter plan, the €10 million, if that's not spent by the end of the year, is it rolled over into next year? How does that work? It's additional funding, I know, but I'm just wondering how that works. And also, since winter won't just be a 2018 thing, unfortunately, we'll get there again in 2019. Is there a plan? Because as we sit here, the winter initiative, I mean, it hasn't been published. The NHS, we know, publishes theirs in September, but we haven't seen the winter initiative. And I know that what you say, Mr. Coniston, in regard to what's happening, but you're listing the sort of stuff that should be happening anyway. The idea that that's an extraordinary intervention because of winter, I think is a bit much. What's on your list is the sort of normal, every day-to-day activity that should be really happening in our health service. I would find it extraordinary that that doesn't happen every day of the week. But specifically with regard to the money and 2019, and also the funded workforce plan, and Mr Mulvaney, you and I have spoken about that previously. So there is no funded workforce plan, as I understand it. The matter was referred into a third party for negotiations, so maybe you can share with us at what stage that is at. I have more questions, but I'll save those till after. But my final question in this round relates to cervical check. We were all, I think, touched and saddened to read about the case of Julie O'Reilly in the papers, I think it was in the Irish Times at the weekend. 4 times she was tested, and 4 times the diagnosis was not given to her. There were precancerous cells there, and 4 times they were missed. So. And I know Keane O'Carroll was writing in the paper, I think it was yesterday or the day before, that still there hasn't been an on-site audit of the testing labs in the States. So perhaps you can comment on that and just give us an up-to-date as to whether or not all of the labs, and I'm talking about the ones in Honolulu where they initially the referral was made to Texas, and then there was re-outsourcing of the outsourcing. I don't want to get into a debate about outsourcing because you all know my views on that, but just with regard to every lab where the tests are analysed, has there been any on-site testing? Because my read of what was said in the paper is that there hasn't, but you might be able to confirm for us if there has, where it has been done, and maybe share the results of that with us. We did, during the course of one committee hearing, ask officials if they could give us a breakdown of the results between each lab, including the outsourced and the re-outsourced and perhaps re-outsourced again labs. And we were told, now this is months ago, and we were told at the time, yes, that's grand, we'll get that, there's no bother at all. We still haven't got it. And it appears every time we ask a question that there's more, it becomes more and more instead of less and less complex. So perhaps that can be shared with us. Thank you, Chair. Thank
you, Deputy O'Reilly. Minister?
I think they're all for John. I don't know, is there anything you want me to answer specifically? John, if you want to come in first, and if there's anything you want me to answer specifically, I would be happy to do so.
Thank you. I'm going to ask my colleagues, Anna Connor, to talk about winter planning, and Damien McCallan to talk about cervical check. Can I say a word or two about Christmas leave and staff rostering, just to open up with? I cast my mind back over the course of the past year, and I think we owe a debt of gratitude to staff. Have a think about what happened over the course of the last winter in terms of snow and storms. Many staff stayed, slept overnight. Okay, they didn't go home. Okay, they stayed to fill the next shift. Okay, so through this committee, I think we owe some staff, in fact all of our staff in the Irish Health Service, a debt of gratitude for all of that. So staff go beyond what's in their normal day-to-day job description when it's needed. So that's one point. I'm not quite sure where the Taoiseach has got his impression from. One of the things that we do, okay, and this may be something that we need to explain a little bit better, is that during the course of the last part of December and the early part of January, we do take a view to suppress electives. Okay. And that's sensible because non-urgent operations rescheduled into the back end of January or into February does allow for some extra capacity. Okay? So rostering in that sense takes place, and that's maybe where we need to explain things a little bit better. I think we also need to consider that many of the departments that we have are single-handed in respects, particularly in rural locations. Okay? And we also need to think about how we actually roster around those staff.
Comments were specifically directed at nurses, doctors and diagnostic staff, and I think it referred very specifically to the acute setting. And I welcome the sentiment with regard to healthcare workers, and we share it on the committee. And I would say to you, there's no difficulty on with the people in this room in acknowledging the hard work that's done, we weren't the ones that were pointing fingers, but there weren't additional people on leave when the trolleys went over 700. It was in the context of trolley weights. So we are talking very specifically with regard to the acute setting and the accident and emergency.
Yeah, I'm aware of that, Deputy, and indeed electors are part of that acute front end in time to time. Can we maybe just move into winter? Can I ask Anna Connor to say a few words about winter and we can come back to that?
Hi, Deputy, and I think your statement that winter is longer than just December is absolutely accurate, and we are planning around that. So the plan that we are putting in place will in effect run from the 1st of December through to the end of March. Within that, we are looking at a number of options, and again, in terms of a lot of the activity that has been referenced, a lot of that should be normal activity, but there are exceptional things that we are also doing. So for us, there's 3 key components to how we're addressing it. We have I suppose, a winter preparedness piece. That includes the introduction of winter-ready clinics for people, so we're targeting particularly vulnerable groups. People who are over 75. One of the things that we know from the data is that we have a number of people who need ambulatory care who can be seen in other locations. So we've known this for a few winters. So we're enhancing our efforts on that front, looking at extended hours outside.
Sorry, when you say enhancing the efforts, that means building on what was done last winter?
Yes.
Okay, so maybe it might be difficult to do it here, but you might provide us with,
absolutely,
you know, just an identification, a written identification of the areas where there was increased activity and where it's intended to intensify that.
And I think within winter we're also targeting in particular a 4-week period, the last 2 weeks in December and the first 2 weeks in January, as part of the overall winter plan, because we know, and again evidence from previous years and reviews of previous years tells us that we have particular challenges in those weeks, and that is looking at enhanced hours available in terms of within community services, because there's often a perception that the hospitals falling over and the community isn't open in some areas. So we're looking at having more services available within the community, enhanced supports available to GPs, enhanced diagnostics, working with private providers, looking at having, I suppose, a different approach to how we bring people into hospital at all. So there's a particular 4-week period within the overall winter plan that we have another set of measures,
and that's from December. That's the first.
Yes.
Okay, and you're talking about increasing capacity in the community then,
yes.
And you've a recruitment plan to go with that, or is it that?
We're looking at, well, we have, we haven't got, we're not going to be recruiting staff per se. We're looking at how we use the staff we have, because again, in community services, once you get to mid-December, the activity changes. So we are talking to managers, and managers are talking to their staff around who's available in terms of doing things differently. We're asking people to redefine what normal activity might be in those 4 weeks in particular. It is often the case in community services that people don't want to come to appointments in primary care centres with children, etc. So we're looking at our range of professionals, looking at how we can actually utilise our workforce differently in those 4 weeks in particular. So there's a very intensive effort going on to look at actually the whole set of supports available across the community and acute.
When will the plan be published?
We're at the final stages now in terms of working with the department.
Well, you really are now, because it's the 1st of December very shortly.
Yeah, well, the publication of the plan doesn't mean we haven't been working on the plan since September. So we actually have had final meetings with the groups and CHOs back on the 11th of October. And we are now implementing through the groups and CHOs how we're going to deliver all this. We have finalised how we're going to allocate the funding and to where, and we're in discussions with the department about just all of that now, and it is very much at the final stage, so it will be published. We have an ED task force date in a couple of weeks, but the work has been going on, and we are at a stage where this is already being implemented. We're not waiting for the publication to start implementing it.
I'm confused. I'm sorry, Chair. You're not waiting for the publication, but people are implementing it.
As in, we're working with the services, because part of the challenge with winter is that we need to clear capacity in advance of the busy period at the end of December. If we clear that capacity too early, we end up filling up again very quickly. So we have a lot of work going on to ensure that we have a lot of supports available to kick in from December.
And is there a target for clearing capacity?
There's a target in terms of we're looking at how we can allocate home care. So we have identified 9 key sites of concern, predominantly around the Dublin area. So we know that we have a home care challenge, in particular in Dublin. We can see that effect in our Dublin hospitals. And we are looking at how we can take people out of hospital throughout December. So a lot of work has to go on with our providers to actually build that capacity. So we're working with our home care providers to ensure that they have people available to take people out as well. So there are a number of different strands of work that are set out in the plan that you will be able to see.
And with regard to the publication date?
Yeah, I don't have an actual date of publication. We're signing it off now with the department. We've had 2 meetings this week. We have reached agreement in terms of how we're going, so it can be signed off very quickly now.
Okay, so it's 15 days to the 1st of December, though. Is that right? Yeah, okay, sorry, Chair.
Yeah. But the work is so that the plans are, so we've been working with our
17 days.
services, so the services are going to be ready. It's not that we're starting to engage with services now. We have been
Okay, so the
engaging for a
engagement
number
has happened with
since
services
September.
already.
We've been working with services since September to look at actions, to look at how we can implement actions. We have a group that meets every week to address this and has been meeting since September.
And is this the same group that was meeting last year?
It's slightly different.
In what way is it different? Sorry, Chair.
I'm going to move.
I know, I
on.
understand that, but that's an important. In what way is it different?
But they're just different people, so we have...
Okay, but it's made up of the same.
We have the same type of
personnel,
people,
just different, same
across
titles.
community,
different...
acutes, our SDU colleagues,
Okay.
clinical
and
colleagues.
communication has already happened with the people in the sites who are going to be delivering the...
Absolutely. So the national directors in acute and community
the
services...
plan's not ready yet, but they've been working to the plan. You can see how that is a bit confusing.
No, I think all we're saying is that we haven't published the plan, but I think we have agreed the actions within the plan. Some of these actions are not resource dependent. They are process changes, and they are all being worked through. So there's only an element of the plan that relates to additional resources.
Could you share with us what's publishable at this stage, perhaps?
Yeah, I mean, we're very nearly there, so yes is the answer.
O'Reilly, you had questions in relation to cervical check.
I
and
did.
I'm going to
Thank
move on
you,
to
Chair.
Deputy
Thank
Murphy.
you. Yes, thank you, Chair.
Yes, Mr. McCallion.
Thank you.
No, yeah, that's
Thanks.
fine. So just a couple of points. Just in terms of the labs and the audit visits. So Dr. Scally visited all of the labs that were in the programme, both those that were historically there and the current laboratories. And as you know, in terms of the two current laboratories, concluded that we were in a position where we could continue to use those laboratories and in terms of extending the contract. He also had a set of recommendations. There's 4 specific recommendations in his report in relation to quality assurance, which would include quality assurance of laboratories. Key for us in that, and one of his observations, it's not a recommendation, was the lack of a cytopathologist in the programme was a deficit. We advertised for that. We'd advertised it actually before Dr. Scally's report. We knew this was a gap. We've been unsuccessful in that. We've extended the date. We haven't been successful. We're in discussions now with someone overseas, just on a particular contract to get someone in. It's critical that we get that in. We've also appointed a quality and risk manager to the programme, who's basically addressing 3 of Dr. Scally's 4 recommendations in terms of the QA structures, and we expect to have that bit of work completed before the end of the year, which would mean we can then move into visits in the new year in relation to the laboratories. Essentially, the new model would see us visiting those on an annual basis. There was a significant gap, I think, between visits in previous times, and Dr. Scally had made a recommendation or made an observation, and we've picked that up, that we will do that on an annual basis. So Dr. Scally has visited all of the labs. He's also doing a follow-up piece of work commissioned by the department in relation to one of the historical labs also in the US. I think it may have been the one deputy you were referring to there as well.
But the question was about an on-site audit. I can come back in.
Can I allow you to come back with your supplementary
Thank you.
questions? Yeah, thank you very much. Deputy Murphy.
I'd like to welcome you all in here this morning and to thank you for giving us your time. No disrespect to Minister Daly, who is a friend of mine, but I am very disappointed that the Senior Minister is unable to attend here this morning. Obviously, Brexit and the Cabinet meeting is very important, but I suppose I'd just like to note that the quarterly meeting was already postponed with him. There are 4 quarters in a year, so it's important that we do meet with the Senior Minister before this year is out. Just a few comments first on the Minister's opening statement. I'd like to acknowledge that he has acknowledged the dedication of the health service workers, and I too would like to say how disappointed I was with regard to the Taoiseach's comments earlier about the workers during the Christmas period, and I think his comments were very, very unhelpful. I'd like to stress the importance of the winter planning, and it amazes me that every year it seems to be a surprise that there's more people need to go to hospital, and there's just, it seems to be an emergency or a surprise every year when it's quite obvious that it's going to happen. I was going to ask for more details, but Ms O'Connor has already outlined the details. With regard to the National Development Plan, the increase in beds seems very aspirational to me. Now, I hope it does happen, but I just would like to comment on how he can how he think he can go to an increase of 2,600 bed capacity when there is a maximum potential of 319 this year and early next year. It just seems a bit aspirational. And with regard to the first outpatient appointments, it's great that they're going to try and put a dent in the backlog, but what about the new people that will be coming on stream as well, awaiting first-time appointments? And can I ask you if people and GPs are still being written to or texted or rang to know if they still want to attend their first appointment? I think that was putting undue pressure on both GPs and patients themselves. I also actually would like a comment from me on the Ombudsman's comments this morning about his disappointment that the HSE has not fully implemented his 2015 recommendations on the learning to get better. So the HSE at the time accepted the 36 recommendations, yet there's only 10 fully implemented, 17 partially, and 9 either not implemented or still being considered. So after he going to the trouble, I suppose, of doing the report, I'm wondering why all 36 recommendations haven't been implemented. And Minister Daly, as your quarterly visit here, I just have a few questions for you, please. Bantry General Hospital, which is in both our constituency, with regard to the mental health services there, so your remit. I have submitted numerous PQs and I cannot get the answer to the following, so maybe you can either give them to me here or get back to me. Is there a dietitian in situ to speak to people presenting with eating disorders? What consultation facilities are available to those presenting with mental health issues? And what are the staffing levels? As late as yesterday, I got an answer back to a simple question, what are the staffing levels? And I couldn't get an answer. So, I mean, there's either 10 or 20 or none or whatever, so I would like an answer, please. And again, with regard to a facility in our own constituency, Lisheen's House, as you know, they get no Section 39 funding. I was wondering why this is, and why also they had to wait for a decision that was due in March, to wait till October for the decision, which turned out to be a refusal. Now, I did ask the Taoiseach yesterday, but he said to ask you, so I'm doing that now. I have a few more questions, but they're directly for the Minister. I couldn't expect Minister Daly to know, so I'll wait for that meeting.
Deputy
Thank you, Chair.
Thank you very much. Minister, do you want to come back directly?
Yeah, okay. Thank you very much, Deputy, and I apologise for being such a disappointment to the members, and I will do my best to live up to...
Get over it. Oh, we love you.
Yeah, it's always hard being in the shade, but anyway, notwithstanding that, I'll do my very best to live up to it. The quarterly meeting, just to make the point that, I mean, it is unique for this committee to have quarterly meetings with the Minister. Not every Minister has quarterly meetings with their corresponding committee, and Minister Harris, to be fair, has always prioritised and tried to attend these as a priority, and I know I catch the flack more often than not when he can't make things, but it certainly isn't out of a lack of interest on his part. I know you're not suggesting that, but I just want to make that point, that he has always, tried to prioritise his attendance here at these quarterly meetings. Just to correct as well the Deputy, I mean, the Taoiseach did not criticise frontline workers, and I know there's a political, I suppose, attraction for all of us to reinterpret what the Taoiseach said, but to be fair, I mean, the Taoiseach referred to the management planning, our workforce planning, and availability of staff, and Deputy O'Reilly touched on it there about diagnostic staff, and I think that's the point. I'm not speaking for the Taoiseach. He's a very articulate man and well able to articulate his own views, so I don't wish to interpret what he said, but I mean, there is a point to be made that a lot of people accept, whether we like it or not in this room, and that is that there are some steps that can be taken to improve the workflow and the patient flow at different times. So that, for example, if a lot of people come into an acute hospital and if some of the diagnostics are not working, only 9 to 5, and could be made, working longer term, then you could get more procedures done. And there's a merit to that statement, and I think a bit of focus on that debate is welcome, and he certainly wasn't criticising frontline staff. You asked about bed capacity, Deputy, that's over, is it 10 years? I think the bed capacity is to be achieved. You talk about 319 in 1 year, but over 10 years, how you get to 3,200. That would work out over that period. You talked about outpatient appointments and new people coming into it. Yes, I mean, the do not shows is only one part of that. There's 30,000 hoping to be eliminated from that list when it's tidied up a bit. But of course, we are working towards, you know, the Sláinte Care has a plan to bring the level of care to a lower level, more people to be treated in the primary care centres. And that is probably the answer to your question: how do we intend to deal with the new clients that are going to be coming onto the list, as well as dealing with those long waiters, is your question essentially.
Yes.
And that's part of the overall reform that's very much at the heart of Sláinte Care, which is reducing the level of care and treating people and giving them appointments closer to home. You talked about letters to patients. I suppose that's part of the central validation process, where it is necessary to write to people whether they still want that particular appointment, and if they're still waiting for that appointment, or if they have gone and don't need it anymore. The letters to the GPs have to happen as well, because you have to inform the GP as they're informed of the appointment.
Why is it necessary, Minister, that they are written to
well, I think if we want to essentially validate, and if we want to make sure that people, you have to notify the GP as well of any change. And yeah, like, it's essentially trying to get to the bottom of the do not attends. That's what we're doing. And yes, there's a bit of inconvenience for everybody because they're getting additional letters, and their GPs are. But if we want to be fair to the system and we want to improve its accessibility and get more people into it, we have to do that.
But could you not write to them to say it's important that you attend? Or if you do not wish to attend, or if you cannot attend on the appointment you got, to refer back? But it's just putting people under undue pressure. People are saying, oh, maybe I'm not too bad. Yeah. So give someone else a chance. Or I just think the wording of the letter could be better. Yeah,
I suppose just to answer specifically about the GP, I mean, in some instances people have moved house, or they're not, so you kind of have to have that cross-check that the GP is written to, as well as, I know it's an administrative probably pain for the GPs, but it's a pain that I think might be worthwhile. And if we can bear with it to get those lists down and get the DNAs taken out of it, if we have 500,000 people not showing up, and then we have a number of people that are on the list that don't need to be on that list, then we could tidy up our figures, I think. So the overall objective is approved. I appreciate what you're saying, and maybe the language of it we can see that, but it certainly is not to put pressure on people. It's just to ascertain as a matter of absolute fact. You looked for an appointment 18 months ago, you still wait for that appointment, and we
maybe
need
the wording
to
would
get that information. I'll take on board your point about the wording. You asked about Bantry General Hospital. I'll come back to you with more specifics, Deputy, on the actual. You asked very specific questions there about the staffing levels at Bantry General Hospital, at the mental health side of it there, I presume, as opposed to the General Hospital. You're talking about the mental side of it, the mental health side of it, and a dietitian and the availability of a dietitian and what consultations are available to patients. I'll come back to you directly on those with specific, and I regret that you haven't been able to get that information, but I will ensure a very timely delivery for you. You also raised the issue of Lishin's house down in Skibbereen. I'm very familiar with that issue, and I know you raised it, and I had just left the Dáil yesterday. I wasn't aware you were about to raise it. I thought QPL had finished questions of promised legislation. I met with the people at Lishin's house last Friday. I'm well aware, as you can appreciate, of that facility there. Section 39 funding is administered by the HSE, not by me, popular to some belief locally maybe, and the people in Lishin's house certainly were of that. I allocate to the HSE, they allocate to organisations. When I would look at the number of organisations that are availing of funding under mental health, which is where Lishin's house come under, there's 1,050 different organisations in receipt of funding from the HSE, ultimately from the department budget. So, I mean, the myriad of organisations receiving money is not questioned. There's 1,050 organisations. But there is a place called where we have to have corporate governance, and we have to have clinical governance, and I've explained this to Lishin's house, and that in order to avail of funding from the HSE, it's not just simple enough to request it. You actually have to comply with certain, responsibilities vis-a-vis, and they have to notify that, and they are well aware, Lishin's house are well aware after the meeting with me on Friday, what's necessary to do. They began an engagement with the mental health side, they didn't see it through. Then they went over to the other side, to the primary care side, and they looked for counselling funding. And again, there was an issue there with the amount of and availability of information that they were supplying to the HSE. So, I mean, I stand over the HSE's right to ascertain and determine the clinical evaluation of any service that's provided, whether it's in mental health, physical health or any other health, and Lishin's house accept that in full, and they now are going off to have their services evaluated and have the clinical side of it evaluated. Because we cannot just distribute money, whether they're in my constituency or they're in any other constituency. There is no facility where we can just distribute money to an organisation based on they're a great organisation doing well. They have to comply with the governance procedures that the other 1,050 organisations that interpret the country have complied with.
So they didn't comply with?
Well, Leashing's House are well aware. I've had a meeting with them on Friday and made it quite clear to them they're under no illusions whatsoever what they need to do. And why you talked about the length of time and the delay, and I heard you mention that in the Dáil yesterday as well, the length of time, that was waiting for information to be returned by Leashing's House. But look, I don't want to be going into any further detail of it. If you want to talk to Leashing's House, they will tell you what I explained to them on Friday, and I think there's no misunderstanding there on the part of Leashing's House.
Okay, so they have to reapply and do what?
And they have to do a clinical evaluation of their services.
Okay,
to
thanks,
provide
Minister.
HSE with that.
Thank you, Deputy Murphy. Before I go to Deputy Durkan, could I ask a number of questions? The first is directed to you, Mr Breslin, and to Mr Connaughton. In relation to the HSE service plan, which will be produced now in the next number of weeks, invariably the HSE service plan does not deliver because the budget overruns by up to 700 million, as it did this year. So what guarantee can you give that the service plan that's about to be produced will come in on target next year, because there is a divergence of up to 700 million each year? And Mr Mulvaney was here a number of weeks ago and he explained the various components of the overrun, demographics, unforeseen events, etc. But surely in a service plan these events must be factored into it. So can you guarantee that the service plan this year will come in on target? So that's the first question to Mr Breslin and Mr Connaughton. The second one is to Ms O'Connor, and I understand that the winter initiative is well underway in relation to planning, but surely the winter initiative plan should be well advanced, if not delivered, prior to the 1st of December. Surely you anticipate the winter coming, and the winter plan should be developed long before the period that it's going to cover. So you might just go through why it has taken so long this year to develop the winter initiative as opposed to other years. And again, coming back to Mr Connaughton, in relation to the trolley count, you say the trolley numbers are decreasing from the first quarter of this year compared to the trolley count last year. That's not the figures that I have been calculating. The trolley count is going up month on month, year on year. There is no reduction in the number of people on trolleys month on month since the beginning of this year. It's going up, so I'm just wondering, are you using different figures to the figures produced by the INMO in their trolley watch? And in relation to validation, the numbers waiting for inpatient treatment have fallen from 86,000 to 72,000. In relation to the treatment, the number of people waiting for treatment has fallen from 86,000 to 72,000. How many of those have actually been treatments as opposed to validating people who no longer require the treatment? And the final question is in relation to Sláintecare, which we have discussed time out of number here. There seems to be a huge lack of urgency in relation to the implementation of Sláintecare. And one aspect specifically is the 2,600 beds that are to come on stream over the next 10 years through the National Development Plan. But also those beds are identified within Sláintecare, but it will be 2021 before there is any move in building new beds. There are 240 plus 79 beds coming on stream in the next number of months. But to build new beds, which we need for our changing demographics, they are so far down the line that it seems inconceivable that our demographics will be able to be accommodated within the bed structure that we have at the moment. So the first question was in relation to the service plan.
I might take that one, and I'd take Sláintecare as well, and I'd ask John maybe to take some of the other ones. In relation to the service plan, it is very regrettable that the supplementary estimate is the size it is in relation to the current year. I wouldn't accept that it's 700 million every year. We were here last year with a supplementary estimate of 195 million, and in fairness to the HSE, there were significant parts of that that were centrally made decisions. So, for example, there were 75 million in bringing forward of the National Pay Agreement last year in that 195 million. So there will be times in a year where government makes a decision to take a policy initiative, or government makes a decision on pay that imposes costs on the HSE, and government makes a decision to propose to the Oireachtas that that get funded And so a supplementary estimate is not unique to the HSE. That happens across the public service. The HSE, as the largest funded organisation in the state, when it has those issues, they are very large, millions of issues. For other departments, they may be tens of millions. For the HSE, it's hundreds of millions. That does not take away from the regret that I have in relation to the 700 million this year. That's substantially beyond any type of margin around government making decisions over and above what's in the service plan. There's some of that, the subsequent decisions made by government, but the slippage this year is beyond what we would plan for, and it's beyond what is expected. And we will certainly be working. We have already started into the process with the HSE of developing the service plan for next year. We're advanced in that, and the objective is that we develop a service plan that is fully funded, not that is partially funded, and that's our objective. In relation to Sláinte Care, I've talked to the Chair before, and from here it looks like a lack of urgency around Sláinte Care. From where I sit, I see people running to get Sláinte Care implemented. I see the Executive Director for the Sláinte Care putting huge focus on it. I see the teams across the department and across the HSE putting a huge amount of focus into getting Sláinte Care done. And I think the implementation plan for next year that will be developed next month will show in a very practical way exactly what the milestones are, and we will have significant milestones delivered next year. I have a confidence around that. I think one of the areas that we will be able to show form on is one that the Chair has always raised when we've been forward the committee, and that's to put a framework in place for general practice. That starts to modernise general practice and makes it more sustainable and attracts people to work in that area, and I'm confident that that will start to bear fruit. In relation to bed capacity, I would say two things on that. One, you've referenced the 240 beds and the 79 beds, and we will make decisions with the HSE on further bed capacity to be introduced in 2019-2020 over and above that. So there will be further beds to be introduced. But I think there is one thing that is worth reflecting on. The bed capacity report says that without reform we will need over 7,000 beds. So it's not a bed capacity report that's about 2,600 beds. It's a bed capacity report that says 2,600 beds, but with very significant reform, because how we're currently organised and how our resources are distributed, and this may go to some of what Deputy Donnelly was asking about at the start, is not the most effective and efficient way to organise a health service. And Sláinte Care shows us how we not only right-size the health service, and we will need to grow it, but also how we change how it's organised, and there's significant change required. We have to shift our health service away from an acute focused episodic health service into one that's preventative and works with people on diseases to avoid acute presentations. And if we don't get that right, we won't be able to tackle the demographic challenges that we face. We will have plans for further bed capacity, but we've also, just like the GP framework, we also have to more strongly support and plan the shift in resources that we're going to need, so that we have more integrated care and less focus on beds as the only part of that solution.
Thank you, Mr. President. Mr.
Can I add, maybe just add a word or two on that particular aspect before I turn to the other things? It's also important to consider that the introduction of new capacity in line with Sláinte Care ambitions needs to consider not just infrastructure which is required in terms of new physical beds, but also the workforce that we need to do. So there's more than just one plan here which is required. And if you ask me, I think there's as much of a constraint on attracting and retaining workforce inside Ireland to be able to crew up for those additional beds and the capacity we need as there is in terms of finding the capital to actually make all of this happen. So I think it's important we understand the requirements for whole system planning around this. As regards trolley count, INMO do calculate things differently, but the HSE figures I've got the July, August and September figures to hand. So July, the HSE count is down 2.7%, August is down 4.6%, September is down 4.6%, and I know that the October figures are likely to be down around about the same amount. They're not yet released. Okay.
On that point, how can there be such I know the numbers are counted at a different time in a different way. But are the HSE figures published? Can we see them,
yes,
so that we can compare them with the INMO figures? Because the INMO figures are going up month on month, year on year. There is no doubt about that.
There is a piece of work we need to do to reconcile both sets of figures. I think that's something that I had as an ambition around the ED task force some time ago, and I think it's something we need to do again. Okay? Because we should be counting on the same basis.
But how can there be such a how can there be such a disparity between the HSE figures and the INMO figures? I mean, people are either on a trolley or they're not on a trolley.
Yeah, I think until we do that exercise and we do it on a site-by-site basis in terms of how we count, I really won't be able to answer that in any detail. But I do think we need to do the exercise to reconcile it.
There's also a time period, Chair, because there was a surge at the start of the year and performance disimproved at the start of the year. John is right. Once we've come into the summer, we've seen that we're coming below last year's trends, but actually if you look at it year to date, we're still behind last year.
Yeah, and perhaps a more meaningful figure is the length of time that somebody spends on a trolley, rather than the number of people who are on trolleys. And I think that would be the most meaningful figure if it could be produced.
You're absolutely right. Patient experience time, which is how many people are on trolleys for more than 6 hours, or in E&D for more than 4 hours, or 24 hours, is actually a better measure. Most other jurisdictions use the patient experience time to mark what they're doing around the provision of emergency care.
Thank you. And my last question, I think, was in relation to treatments versus validation. The numbers have come down from 86,000 to 72,000. What proportion of that fall has been validation and not treatment? Okay,
it's my impression that most of those are treatment. Okay. Just for the record, we've had a 16% reduction overall since July 17, with a 32% reduction in the longer waiters. Okay, and the whole purpose around the NTPF and HSE strategy over that time period was to target those that were longest waiting. Okay, so I don't have the figures here, but my impression is that most of those are treated rather than removals, and that probably stands up because the validation exercises took place after that time period.
Okay, thank you. And my time is up, I'm sure, but perhaps Ms O'Connor might come in at a later date in relation to why the winter initiative is so late this year. But I'm conscious of other people wanting to come in, so they may actually ask you the same question, but I'll come back to it if they haven't. So, Deputy Durkan.
First of all, I want to welcome the Minister and the HSE and the respective officials before the committee. And just a couple of questions. I fully appreciate, that the quality of the service provided throughout the health services at all levels and the degree to which staff are dedicated. It's not that I worry about most. It's the deployment I worry about, and it's the deployment I've raised on many occasions in the past. So the first question is, to what extent do you feel staff deployment and resource deployment and equipment deployment within the HSE, within the health services in general, the public hospitals, has an impact or a bearing on the delivery of services? First question. Second question is, I've raised this on numerous occasions as well. I believe the structures are wrong. I believe that has not been addressed. Hopefully it will be addressed. But the structures in terms of the delivery of the services. I'll give you an example, Mr. Chairman. If there are, for example, 20,000 people on waiting lists, for example, what do we do about it? Do we start at the 20,000, or do we start working from there and do a calculation as to how long it will take to clear that 20,000 and by what amount the list will have increased at the other end in the intervening period? Or do we decide on a strategy to clear the 20,000 independently of whatever else is happening and deal with the oncoming cohort of patients as they arrive on the scene? Because I believe, and I've said this many times before, Chairman, I don't believe there's a need for waiting lists at all, except for minimum waiting lists. I don't think there's any basis at all for having a 2 or 3 or 4 or 5 or 6 month waiting list. I can't understand it. But if we resort all the time, rely on the long list and how long it would take to deal the long list, you can do a calculation any time and say, well, it'll take us 5 years before that patient is going to be dealt with, or 6 years, depending on the emergency cases that come through in the meantime, or 10 years, or whatever. So we have a problem there. So I want to know, has any audit been done to identify the deficiencies in the system that slow down the through flow of patients? Well, I know, because I got a reply to a parliamentary question yesterday, as I did promise I would, to the effect that were 102 or 103,000 staff all over employed in the HSE. There's now 135,000? 13,000. That's not what it says now altogether. But the increase in staff that have been, the number of staff that have increased, where have they gone? Where have they been deployed? Have they been deployed to the areas most sensitive, the areas most in need of intervention, of supplementing the staff levels there? And the last question I want to raise in this one, I have, from my time in public life, seen a long period where we were told by experts that we needed less hospital beds. Less hospital beds. That was the mantra up to 7, 8, 9 years ago. I don't know why that was the case, but that's why it was. And it was going to be dealt with in a different way, and we'd have less beds. Didn't work. Hasn't worked. And I just want to know, in the case of crowded corridors and patients on trolleys in the reception areas of hospitals, can we be assured that there is no vacant space in terms of decommissioned wards around the same hospitals? Or can we ascertain at this stage the extent to which plans are afoot to provide accommodation, actual physical bed space accommodation adjacent to those hospitals, having regard to the experience over the past number of years, and particularly in regard to the winter initiative? There's no sense in moaning about it if we don't do something about it. And there are ways and means of providing emergency accommodation if it has to be done in the vicinity of hospitals. And if there are facilities there which can be used, then I think we should use. The last element that you referred to yourself, Mr. Chairman, is the INMO calculations and the HSE's calculations in terms of trolley waiting times and all that kind of stuff. Maybe let us into a secret as to who is telling the truth. Either somebody is not accurate. So let's know about it. We need to know about it, because otherwise the entire health services are being damaged as a result of there being an inability to deal with what is a very simple issue, to my mind. That's the first tranche, Chairman.
Mike, because I've confused the committee, the figure you were quoting, 135,000, that's the number of people, but a lot of them would be part-time. So if you measure it in a full working week, we've 116,000 employed in the health service.
The part-time one's not paid.
They are, but they're paid a part of a week. So you're correct.
And sometimes they're paid more.
It's 135,000, the number of people, if you count them. No. But if you count them in terms of a full working week, it's 116,000, and that would be the one we would generally use. So,
Mr. Chairman, I have to say this now. I used to be in the health board once upon a time, and I always foresaw confusing replies. I am confused now. Because I raised the question, Chairman, about whether those part-time people are being paid. So we have to quantify them as in a whole-time space or a whole-time place, or whatever you want to call it, in the system. Do we have them or do we not have them?
So we have them, and we're not confusing you, because the first question that's there today from Senator Colin Burke sets out both figures. So if somebody is working half-time, you employ 2 people to cover the week. If those 2 people leave and you employ 1 person working full-time, that's still 1 whole-time equivalent. So that's the number that's used to express whole-time equivalents.
Yes.
But there's also a figure of how many people have employment in the health service, and that's your figure, 135,000. And that's correct too.
And there was 30,000 or 29,000 less 4 years ago, 3 years ago. Is that true?
Again, I'd use whole-time equivalents there to compare.
Chairman, I think we're hair splitting at this one now. I'd like to be absolutely clear about it. I'm trying to find out exactly how many people were employed in the health services for 2015 or 2014 or whatever it was, and how many people are employed now. There's an increase, a fairly considerable increase, on 28%, 25% or something like that, and that has to make a difference. So that should be reflected, Mr. Chairman, on the delivery of the services to the general public. Otherwise, maybe and I went down through the list from Parliamentary question. There are consultants. I went down through the list very carefully now, much more carefully than people might think, Mr. Chairman. There was a good number of consultants at various levels, some to a greater extent than others. So my question now, obviously, still remains. You know, there are blanks within the system where there hasn't been a major improvement. There are blanks within the system where we're not progressing in the way that we should. And despite the denials, we do pay high, we do pay top dollar for our health services in this country. And that's not a reflection on the people who deliver the health services, it's a reflection on the methodology for the delivery. And unless we find what's wrong, what's slowing down the system, Mr. Chairman, we're going to be doing the same thing here in 5 years' time. There will never be a resolution to what the kind of situation that we've turned up.
So my point is not to argue with the Deputy, just to clarify on the figures. The answer to question 1 today gives both figures. It says that in 2014 there was 103,000 whole-time equivalents employed, and in 2018, in September of 2018, there's 116,000. Using the figures that you were using, which is the number of employed, it was 121,000 in 2014 and it's now 135,000. You are correct under either measure that there's been a significant increase.
I suppose, Chairman, can I just be helpful to bring some clarity there? The number we need to focus on is the number of salaries being paid, full-time salaries being paid, which is 116,000, up from 103,000. Obviously, lifestyle is an issue for many staff, and some people like to work half-time or part-time, and it takes 2 or 3 people to fill that whole-time equivalent, and that's the difference we're trying to highlight here, Deputy. But we need to keep control of the narrative as well, that the figure hasn't gone from 103,000 to 135,000. We need to make sure that people are absolutely clear on the weekly salaries being paid, full-time weekly salaries, which is 116,000, and that's the figure we probably have to stick with, because people are entitled to job share, and increasingly that's an option for people, and it's being accommodated by the HSE, but we do not want that to be used to distort the change. You asked another question about where are these people, where are these positions being filled. I suppose a lot of these positions have to be filled in front line, where we are struggling all the time, and obviously there's an administrative aspect to it as well for those increases. But we must also note the increases in procedures being carried out by the HSE on a yearly basis, year on year, which is very significant, and the number of people going through the system. And that's probably the measure we should be looking at versus the measure of people employed in the healthcare system.
There's no extra cost by having more people involved that do the same job.
No.
And there's no reliance on agency people doing any of those jobs.
Well, that's a separate debate. The agencies is separate, but there is no extra cost, whether it is 116,000 people are delivering that service or 135,000 people are delivering that service. It's 116,000 whole-time equivalents, which is the salary, weekly salaries, full weekly salaries.
How many agency places are we carrying now?
Yeah.
On a normal week?
I'll ask the DG maybe to comment on that, on the agency side of it.
Okay. Deputy, I don't have an actual figure for the number, but what I can tell you is of our total pay cost, total pay, including agency, 95% of it is not going in agency. So about 4.5–5% is going in agency. And that varies depending on which section of the health sector you're in. And that's not to diminish the fact that we would prefer to lower, in many cases, our reliance on agency. But it's about 95% is not agency, and about 5% of the overall pay bill is agency.
But the agencies cost more.
They do, Deputy. There's a premium for employing staff through agency.
How much?
It varies depending on whether it's support staff up to medical staff. In some cases, in medical staff, it'll depend on where exactly in the country you are and what the market is like. So the premium can be from 20%, and it can be significantly higher than that. So it is in our interest, and it's something which we pursue constantly, which is trying to limit the amount of agency we use, get the best price for agency. And it's not just for financial reasons. Obviously, there's continuity of care reasons why we prefer to have a lower reliance on agency. There's always a case where agency may make sense for the short term. It's when you become reliant in the long term on it, it becomes problematical. And it is a problem in certain areas of the service. We've been upfront with that.
Come in, and then I'm going to move on to Deputy Kelly.
Okay, the disused accommodation as well.
Just very quickly, you asked a question about how we do the calculation for how we look at waiting lists and lay plans. Okay, all of these plans are laid on what we call additionality. Okay, which is what extra can we actually put into the system feasibly, and that's where NTPF comes in, because their funding is to create that additionality over and above what the Irish healthcare system can provide. You also asked about what audits have we taken place on the flow of patients through the system. Okay, we actually have a number. Just two things on that. We've got a number of initiatives running around flow in various parts of the country, and this is very well clinically supported, particularly in places like Galway and Cork, and in some of the Dublin hospitals. And what might be of interest to you is that in a number of past committees, deputies have asked about, well, how do you spread best practice throughout the system, which I think underlies a lot of what your question is. So very recently we have constructed a best practice guide that takes the best of what we do in the Irish healthcare system, and that's now available to all, because it's working well in Clonmel, and why can't we spread that throughout the country and learn from it? So we have now published for the very first time a directory of best practice that has over 300 current examples. It surprised me how many we gathered in such a short space of time, but that now has over 300 examples of best practice that is now up on our website and can be made available to all staff, and we'll be taking steps in 2019 to see what we can do to support the spread of that with some of the additional funds that we have allocated as part of the National Service Plan.
Thank you very much.
Disused ward space.
Can you bank that question,
okay.
and we'll come back to it in the second round as other deputies have. Thank you, Deputy Durkan. Deputy Kelly.
Welcome to witnesses, and thanks for the Minister for standing in. A few questions which I'll address to Mr Conaghan, and I have other questions which are relating to the cervical check issue, which maybe Mr McCallion or Mr Conaghan can take. So it's just a quick fire round because we've only a certain amount of time. Are you considering any structural changes within, Mr Conaghan, within the HSE at the moment as regards, we'll say, the directorates under you? If so, what are they? I think question in relation to winter planning, I think, has probably come up, so I don't want to take up my time with it, except to say that the fact we don't have a plan is crazy. Can you give us the timelines for the development of the new units, the rapid build units in Limerick and in Clonmel? Can you give me the timelines for them? When will the agreement be signed with the drug company in relation to Respreza? This has been going on for over a year. A neighbour of mine died when she was taken off this drug. I've spoken about it publicly. Marianne Kelly, no relation. Her daughter met the Minister last week in Nina when he was opening the facility, and I understand the deal is very close. They want to honour their mother by making sure that every other person affected gets this drug and is signed up to this drug. So when is that? And I have to say the response from the HSE on this has been not very good. Yes, on the communication side. Next question is in relation to recruitment. Will you consider for 2019 decentralising recruitment? All the experiences that I have, and of a lot of people coming to me, is that centralisation of recruitment up to a certain level is not a good idea, and it's taken too long. So I've had people who have come to me for nursing jobs who are qualified, want to work, want to stay in Ireland, but can't work for the HSE because it's taken too long. I've had one case where they're waiting 6 months. They want to work in a region. I've had this verified in other ways as well. So up to a certain level, can you decentralise to the regions? I think will work better. Please consider that. My remaining questions are in relation to the screening. Last week, I had some brief questions with Mr McCallion in another forum. The 20 weeks that we're waiting now for women are having to wait to go for their screening. It was confirmed to me last week that women who are triaged, in other words, women who need screening possibly in 6 months' time, are in the same boat as women who are coming for their tri-yearly check-up. And we can't distinguish between them. This could have a negative medical impact on their lives. So, for instance, if somebody has been recommended to come forward in 6 months, or somebody was coming for their tri-yearly smear, they're in the same group with the 20-week delay. They need to be pulled out and distinguished. There needs to be a prioritisation there. I raised this last week. In fairness, very honest contribution back to me. I have to say, one of the best contributions I ever got inside in the committee. But it does need to be dealt with, Mr. Conaghan. And can you confirm that it is being dealt with? Basic facts in relation to the 221 women. How many, unfortunately, have deceased? How many are in the middle of treatment? And how many are post-cancer? I also want a breakdown of the 221, the total number of smears that they had, and the breakdown of the labs that were read in. The fact that we're waiting for this information over 6 months is not acceptable and does not breed confidence. The last couple of questions. When will the audit recommence? It is not good enough that the audit has stopped. All variables have stayed the same. So from the 1st of January on, with all variables staying the same and no audit, that means that pro rata, more women are being affected in some way. So when will it commence again, and how are you going to deal with that? And finally, why is it taking so long? And I appreciate Mr. McCallion giving me information last week, so maybe he'll have an update for me this week. I think, I'm not going to misquote him, but so correct me if I'm wrong, but I think you said on average 22 days. It turns out many people are waiting 3 to 4 months to get slides, women. Now, there is a breakdown here somewhere. What is it? Why are women waiting so long? And finally, Mr. Conaghan, question for you. The impact of Scally, what actions are you taking outside of the recommendations that he has made? Because I understand you will implement all the recommendations. And where there was issues of burden of duty in the labs, where we know now there's been cases settled by the labs where there was a burden of duty. Because I asked the ACA last week in relation to how many cases there were with negligence. But where we know there was an issue with the lab, why aren't those labs being inspected by the HSE? Under any other normal contractual relationship where we know there's an issue with a lab, they would be inspected. They're my questions. Thank you, Chair.
Thank you, Deputy Kelly. Mr. Connaughton.
I know that time is short, so I'll make yes or no answers to this. Start with recruitment, if I could. I agree. It takes far too long. The answer will be considered decentralisation. The answer is yes. We're currently looking at that. I happen to think that downloading as much as we possibly can to make a robust situation for recruitment locally is the way forward. And also maybe fling in something about the importance of making sure that clinicians are involved in decision making as well around the clinical director development programme. Respreza has passed our leadership team meeting yesterday. We have one more meeting to go, which is next Tuesday. Without prejudging what that one more meeting decision might be, if I can give the Deputy a positive vibe that we will be coming to the right decision at that point in time. So that's next Tuesday for Respreza. Structural changes. I think structural changes need to be considered, if any, by the new board and the new DG. Okay? It would not be right for me to think about any structural changes at this interim. Okay? They need to be comfortable when they're in post with the future structure of
but your thoughts on this would be you will be putting forward your thoughts to the board, I presume. You are making considerations in that area.
Well, I've already put forward my initial thoughts to the Chair about the structure of board committees. Okay? But bear in mind that he has not yet got an appointed board. Okay?
I agree.
Want to discuss that with them. Okay? Development of new units, rapid build in Limerick.
Limerick and Clonmel, yeah. The Minister announced it last week in Clonmel. He asked me to raise it in committee with you, your Secretary General in particular, to make sure the money was available. Okay. I don't have the timetable in my head, okay? If I can get back to you very quickly on that, unless Anne O'Connor or Colin. I'll have a chat, I'm joking here, but have a chat with Jim before you do it to make sure the money is available.
He's just passed me an envelope here. Is that helpful?
We always have a chat with Jim.
The chairman would like this as well, because it's affecting us in the Midwest.
Can I turn to Mr McCallion for the first questions on cervical check?
Sure. Just in terms of the slides, Deputy, I mentioned last week that in some cases there was an unacceptable delay for some people. 76 days was the outermost and the average was 22. And that isn't acceptable. We had subsequent requests as well for slides on Friday, Monday and Tuesday of this week. There's about another 30 requests. We've written out to the laboratory saying that we expect them to be able to turn them around in less than 10 working days at max, because they have to take the image, they have to get all the logistics and all of that sorted out, and adherence to the protocol. So I think maybe some of the concern that was arising, as I say, there was a number of requests that came in Friday, Monday, Tuesday, possibly related to that in terms of concerns of individual women or families. And our objective now is to make sure the labs, achieve that within the target. Just going back to some of your other points, we discussed last week, yes, in terms of how we might triage, given the backlog in terms of trying to prioritise. We have managed to prioritise the colposcopy because of the nature of the way they're identified. It is much more complex and proven difficult, as I said to you last week, to make the differentiation between the out-of-cycle and in-cycle. I agree with you that if we can somehow do that within the in-cycle, it would be a much more better way in terms of doing it. It is complex, it isn't straightforward, and we are still working on that with laboratories in terms of trying to do that. We have managed to isolate colposcopy because of the way that they're identified, and that's helpful because they're crucial, because at that point a woman is in diagnosis or potentially even in treatment. In relation to the 221 women and their families next of kin that were impacted by the original audit, just in terms of the clinical status of those, the RCOG audit was intended to do that. That was the process that was set up by government. It's clear now in relation to the 221, based on the consent rate, which is around 31%, that we need to do something ourselves, and I've been working with our own Chief Clinical Officer here.
31% of the 221,
so
just for clarity, 31% of the 221 have consented to
date. Yeah, that's correct.
Then you've got a serious problem.
So overall, the consent rate is quite good at this stage. It's close to 60%. It's 57% at the moment, and that will still continue. We still have to contact some of the next of kin, and there will be some people that will come in later in terms that are still contacting us around that. So overall, the overall rate is good, but within the 221. So effectively, in terms of trying to pull that information together, because patients are interested in it, it's general public interest obviously as well, but primarily patients themselves and patient representatives in terms of planning supports for those, and we've spoken to them. And our intention is to get one of our healthcare audit team to undertake just that sort of clinical status, factual position. The RCOG audit, just to be clear, is a much more comprehensive audit. It's actually going to look not just at the smear, colposcopy, the actual treatment options, so it's a much further clinical review. So we will do that, Deputy, and we would intend, I think, to have that done this side of Christmas in terms of, it'll take a number of weeks to do it. But the original intention, just to be clear, and the reason why we weren't doing that is the RCOG audit was intended to...
Just for clarity, the 2-to-1 audit, effectively, of all the questions, stats that I look for, you'll have before Christmas.
Yes, we can maybe recap on all the questions in terms of the specifics, but our intention is to confirm the clinical position in relation to each of the people that were part of that original audit, so that we're clear. But maybe we can just make sure if there are particular pieces within that.
Okay.
Our priority is to link with the patients, link with the hospitals, and make sure we have a comprehensive picture, obviously anonymised in terms of the people themselves, in terms of feeding that back. Just your last point then was, I think, in relation to, there was two additional points, I think, was the laboratories in terms of the breakdown again in terms of the 221. So again, I mentioned this in terms of an earlier question. One of our challenges, we haven't had a cytopathologist in the programme. That was recognised as a deficit by Dr. Scally. We saw it ourselves and we tried to recruit it even prior to Dr. Scally's own report. We've been unsuccessful in that. We've gone twice. I'm now in discussions with someone from overseas with a view to them coming in and taking up a contract here in Ireland. That's crucial in terms of getting that breakdown, because in terms of the, for example, within the 201 women impacted, many of those will have multiple smears, multiple labs across different periods of time. The labs that were here in the earlier stages will have higher abnormalities because they were detecting more cervical cancers in the early stage of the programme. So we need a cytopathologist to do that work. So while I'm trying to conclude recruiting someone on a full-time basis, because that's an ongoing need. It's not just for that particular issue. I have managed to source someone also outside the state that will undertake that specific piece of work for me over the next 4 or 5 weeks. So our intention is to conclude that separately as well over the next 4 to 5 weeks. So again, we will have that done this side of Christmas. But again, just to flag, it has been very challenging in terms of recruitment around that core resource, and that side of pathology need is crucial for a programme like cervical screening. So.
Thank you very much, Mr.
Mr. Conaghan, I just wanted to answer that last
Kelly,
question.
just one last question then.
No, it's purely the question asked.
Dr. Henry just.
Oh yes, sorry.
Sorry. Yeah.
So why the...
Just, Deputy Kelly, you asked another question about restarting audit. So, audit of interval cancers of all 3 cancer screening programmes is just one component of what is a very broad quality assurance programme. And we note that Dr. Scally's endorsement of or encouragement of people to continue to partake in programmes because they are population based, and it's really important that people continue to attend in order that they reach their stated purpose of detecting cancer earlier and reducing cancer morbidity. And we also know Dr. Scally said that the audit where this all began was flawed in its design and implementation. So for us, it's really important that when we're restarting audit, that we get the design absolutely right from the outset, not just for cervical screening, but for all 3 cancer screening programmes. So we have secured a chair and a group. The chair is a prominent cancer specialist who's worked both in Canada and in Ireland, and I expect she will be starting her work in the near future. And our aim is to establish principles for audit in all 3 cancer screening programmes that are robust, patient-centred, and address the flaws that were addressed through the cervical screen controversy and through the Scally report.
I just want my question answered. I'm not asking another question. It was just to Mr. Conaghan regarding Scally and what...
So the wider implications of Scally and what lessons we're going to learn. Okay, so there's 2 aspects to that. One aspect is the process aspect. Okay, now that in many ways is arguably the easiest bit, because when we actually come to see, when you'll eventually see the implementation plan in response to all the recommendations, you can see that broken out, and we've gone, I think, well beyond the basic recommendations to consider what the wider things we need to do to support better process within HSE. The hardest bit are the bits around culture and values and behavioural change. And to that, I'm happy at some point in the future to give you a short paper on what we're doing around values and action and how we're intending to spread that into clinical staff. I'm happy that we have. I'm happy that we have a number of doctors now on board with a clinical aspect to values and action. So that's one of the things that we need to work on, and it's actually harder, I think, than process actions.
Thank you very much, Mr. Conaghan. We're now going to move to the last member of the committee, Colin Burke. Deputy Conway McGee, I'm going to bring you in, but I'm going to have to ask you to wait for the second round because we have an unusual meeting this morning in that the Minister has been absent and he's just come now. So we're going to go around a second time and we'll bring you in then.
Okay, can I check with you then, Chair? It's going to be about 30 minutes or 40
an hour,
minutes?
I would
Is it
expect.
an hour? Okay,
yeah.
fine. I'll do order business. And
Thank you very much.
Thank you.
Deputy Senator Burke.
Thanks very much, Chair, and thanks to the people here this morning for their presentations. And thank you, Minister. I'm delighted I delayed asking my questions, so you're now here to deal with them. The first one I have is a local one. It's about the hospital in Cork. It's in the National Development Plan. My understanding there was a committee set up to help identify a site. My understanding is that that committee has not met. And I'm concerned that, you know, if we haven't a site, even to identify a site is going to take some time. I'm concerned in particular about the growth in population in Cork. It's gone up by over 130,000 people in a very short period of time. Even if we started in the morning with a new hospital, the increase in population in Cork will be anything up to 160,000, 170,000 people, and it's going to put huge pressure on the Cork Hospital. So I'm just wondering if we can have a timeline as regards the structure being set up. To the initial thing is about identifying a suitable site, then the whole planning process thereafter. So you're talking about a period of 2 to 3 years in real terms. I want this to be moved on. It appears to me nothing has really happened in that issue. The second issue I want to deal with, and it's gone back over some of the, and it's questions I had in, and by the way, that question is about the Cork Hospital is one of the questions I had in for this morning in the written replies. The other question I had in was in relation to staffing numbers in HSE. And it's interesting to look and to thank for the presentation of these figures. And I've looked at the figures. For instance, if you look at nurses, the number of nurses has increased in real terms from December 2014 to December 2018, which is the prediction, is in real terms it has increased by 629 in real terms in that period of time. The number of nurse managers has increased by 1,093. So it's gone from over 6,602 to 7,695. And the number of consultants, and I'm talking about whole-time equivalents, has increased by 397. But the one that I'm concerned about, and I've asked this question before, is there a detailed plan as regards recruitment in the HSE, as regards strategy? And what I'm concerned about is management and administration has gone from 15,112 to 18,131, an increase of 3,019. So that's a 3,019 increase. It's now higher than it was ever prior to the cutbacks or any other stage, whereas the number of people on frontline we don't seem to be able to get. And just can I raise the issue about consultants and agency, and I know it was raised by someone else earlier on. My understanding is that agency doctors have cost 110 million in the last 12 months. Now, if that's the figure, then that means we could actually recruit 500 additional consultants at a higher pay than what's being offered at the moment. And even if we paid them, if you provided a figure of 110 million is equivalent to 500 consultants at 220,000 each. And we have 500 vacancies, and we seem to have a figure where it is not attractive for people to come back, in particular coming back to like Dublin, like say for the cost of housing for someone who's coming back from Australia or anything else. It's not attractive what we're offering. And I'm just wondering, are we going to review that? When are we going to review it? And when are we going to provide a package that will get a far better return as regards having permanent people in rather than employing agency who we're not knowing from one month to the next whether they're there or not. The other issue that I want to ask is in relation to, and Mr. Breslin referred to, we need to move away from an over-reliance on the hospital system. But part of that is GPs. And where are we with the GP contract issue? Because it is a concern out there with general practitioners in relation to not knowing how they can plan the development of their own practice over the next 3 to 4 years, because these contract negotiations are going on for quite a long period of time. I pulled a press release recently which is dated August 2016 where I was looking for the contract negotiations to be fast-tracked. We're now more than 2 years later and we don't seem to have made progress, and I'm a bit concerned. On the one hand, we don't burden the hospitals. On the other hand, where we need people at frontline, we're not encouraging them to provide a service that we require. So they're my questions this morning, and I think they're important from the point of view of the overall development of the health service.
Thank you, Senator Burke. First of all, to welcome you, Minister. Thank you for coming. We understand your absence. Thank you.
Well, no, thank you very much for having me, and apologies for being late. And thank you to Minister Daly for deputising. Thought it was time to throw him in at the deep end. But thank you very much for having me here, for understanding my unavoidable delay. Just a couple of matters. I think I'll ask John to comment on a number of the specifics in relation to the recruitment numbers within the HSE, but from a policy perspective, I suppose just a couple of points. Firstly, in relation to the Cork Hospital issue, which I suppose is obviously a local and a regional issue, but it's actually also a national issue because it's a key part of the infrastructure that we need to get right. The population of Cork, as you rightly outlined, Senator Burke, has grown significantly, and the health service hasn't grown in that region to meet it, certainly not from an acute hospital bed point of view. So we have secured funding in the National Development Plan to deliver the new acute hospital for Cork, but also, as you know, the elective-only hospital for Cork, for Galway and for Dublin, which I think is going to have a significant transformational effect on the delivery of scheduled care and improvements to our waiting lists. And indeed myself and the Director General of the HSE visited Scotland recently. Well, he didn't visit Scotland recently, he's from Scotland, but he brought me to Scotland recently, and we looked at how their elective-only model over there has transformed their waiting lists as part of our process for developing our elective-only models here. So as we're finalising the capital plan with the HSE, once we have that done in the coming weeks, I will, in the department, work to put a structure in place to advance that preparatory work, if I may call it that you rightly identify that needs to be done. So I hope by year end, Senator Burke, we could have a very clear outline as to what that preparatory work looks like, who's going to do it, what responsibility lies with the department in terms of policy formation, and the HSE and the hospital group in terms of delivering it on the ground. On the issue of the GP contract, so we're not talking about this in an abstract concept. Negotiations are going on a weekly basis. There are GP contract negotiations taking place in my department with the Irish Medical Organisation. Both sides have said publicly that they want those talks to conclude by the end of this year. I expect that they will. We have a very sizable sum of money to invest in general practice on a multi-annual basis, agreed with the Minister for Public Expenditure and Reform, myself and the Taoiseach. This is a level of investment that will enable us to do three things. It will enable us to make general practice sustainable. General practice has rightly said that it has suffered cuts, FEMPI cuts, through successive governments during the economic recession, and that we need to move beyond that and address that issue in terms of sustainability. Secondly, the issue of exactly the point you make, how can our general practitioners, if resourced to do so, do more and do stuff that's currently done in our hospital setting, specifically and particularly around the whole area of chronic disease management. And then thirdly, in the whole area of access, we've signed off together as an Oireachtas on a sláinte care plan that does want to see many, many more people be able to access GP care free or at low cost. So how can we do more on access? How can we do more on chronic disease management? And how can we do more on sustainability? I hear people misrepresent my position on this regularly, suggesting that we're only talking to GPs about doing more and we're only talking about giving them more to do more. People who make that argument intentionally ignore what I've just said in relation to a very important part of that conversation being about the sustainability of the existing services and the resources that are required to do that as well. So I expect that to conclude by year end. I think it's a very exciting piece of work going on. Yes, it's taken far longer than any of us would have wanted, particularly far longer than GPs would have wanted. But it is a huge piece of work. It's potentially transformational for the health service, very much in line with sláinte care, and I look forward to it concluding. On the issue of staff recruitment measures, I'll ask John to take you through them. I just would make one point, and you and I have this engagement regularly enough at this committee, but it is a point I need to make. Sometimes when we talk about managers and administrators, there's a suggestion that, not by you, Senator Burke, but sometimes in terms of how these things are reported, there's a suggestion that actually there's no added value to the health service. And of course that's not the case. Many of the questions that I get from members of the Oireachtas, many of the parliamentary questions, many of the topical debates, the commencement debates, are about things like answering your questions, providing information, things like wanting to see reform in terms of how we manage our outpatient department clinic appointments. So if we're putting more people into OPD clinics, they might be counted as administrators, but they're actually very much helping play a frontline role. So I do think we should do a piece of work as a health service and actually further explaining the value added that there is from these individuals who work very hard in our health service. So John, would you like to maybe?
Okay, thank you, Minister. So first of all, you're right, we should be prudent about spending any money that's away from the front line. Okay? In that respect, just so that you're aware, we actually have a business case process for any senior or exec manager that we want to appoint into the system. That has to be the subject of a very vigorous business case, shared with DOH, shared with DPER in terms of the approval process. One of the things that you've commented on is the growth in recent years. Just consider that what we have done is we have created delegated units in both CHOs and in hospital groups, and it's important that we staff these appropriately in terms of the governance. It's useful also to refer to other countries in terms of where we are. So the experience of other countries, the NHS in England, okay, has got a senior management cohort of around about 5% of senior and middle management. That compares exactly with the current Irish figure. Okay? For the very senior managers in in the HSE. It's a figure that's much less than 1%, as an example. However, let's just pick up the point that the Minister has just raised about where admin and clerical particularly take away tasks that used to be done by clinicians. Okay, so we've got scarcity in some of the clinical specialties that we're pursuing, and it does make sense to try and divert some of that, some of those non-direct clinical services tasks onto an admin and clerical function. So that I think is a good thing, because it allows clinicians to run at the top of their licence. And I'll ask Colin Henry just to say a very brief word about recruitment into that. One other thing I should say is that let's look into the future. As an example, we've just been allocated £250 million from the European Investment Bank to bring forward our plans to create more in the way of electronic healthcare records. In order to bring that forward, we're going to have to add some of the specialists, the programmers, the system developers, and the support staff to be able to bring that forward. Now, that might be for a transitory period of time, but as I look into 2019, 2020 and 2021, I can anticipate some growth in some of the management posts to enable that to happen, as an example. And perhaps Colin would say a word or two about recruitment.
Briefly, like many other European countries, we face huge challenges with medical recruitment. The EU Commission itself has predicted that, in the entire EU there will be a shortfall of 1 million healthcare staff by 2020. So we're not alone in facing medical recruitment difficulties. And one of the difficulties we face, Deputy, is that, or Senator, is that we have to recruit for unscheduled care in 29 sites. So there can be no break in unscheduled care. Once we announce we have unscheduled care, be it obstetrics, paediatrics, medicine or surgery or anaesthetics, there has to be somebody there ready to see patients or ready to care for patients. And that explains to some degree our dependency on agency and locums, because such a service by definition is unbroken. To go back to the earlier point you made about the ways people work, Deputy Durkan made, it is a critical enabler of stauncher care, that people, not just the additional recruitment of people, but changing the way people work now. And the Deputy Director General of Operations and myself attended a meeting earlier this week, a conference of health and social care professionals who demonstrate how innovative our staff are, not just hard-working, but they've brought in initiatives in Beaumont Hospital, Kilkenny and in the community and other places where they're working outside their traditional boundaries and bringing stauncher care into practice before it's being implemented. So that is happening through innovation of our staff on the ground.
Thank you very much, Dr. Henry. Sorry, Deputy, Senator Burke, I'm going to, if you can bank your question, okay, because we will be coming around a second time. So now, Deputy Donnelly, to come in a second time. Thank you.
Thank you, Chair. Minister, you're very welcome. Minister, I want to talk to you about the recruitment and retention crisis, what's happening and your views on it. I want to start with consultants. So we know that 1 in 5 consultant posts are currently empty, and that a very small number of consultants are applying for empty posts relative to, say, 10 years ago. We know that in many hospitals it's becoming impossible to hire in consultants, particularly when more experienced consultants are needed. We know that there's been an increased use of locums. It's up by a third between May and October of this year, so going up very, very quickly. There are allegations that some of these locums are certainly not as well qualified as the consultants would be, and obviously they can cost more money. We know that there are several areas are now losing specialist services. So as an example, Kerry University Hospital is about to lose its only histopathologist, which puts cancer screening services, including cervical check, and many other surgical services at risk. My understanding is that Cork is not hiring additional resource, and there's no plan in place yet to deal with this. Tralee has recently lost its rheumatologist. Patients are now being referred to Cork, but in Cork there's a 2-year waiting list with 1,500 patients already waiting to be seen. And I'm told that unless someone has an extremely urgent case, there is no realistic plan to ever see them. This week, Tralee lost its urologist, and we're told that in Kerry they're now struggling to even get the locums to cover these posts. Crumlin, we've discussed before, scoliosis, for example, children are waiting more than 3 years for operations. In St James's urology, the waiting list for routine check is now, for a routine appointment, is now more than 6 years. And the list goes on and on and on. We can talk about hospitals all over the country. The scarcity of qualified consultants has now become so acute that actually they are beginning to shut down services for patients. That's where we've got to. When it comes to nurses and midwives, there are serious issues as well. So the INMO told me very recently they estimate that the service is now short of about 175 midwives, which is a very, very large number. Galway University Hospital has 16 operating theatres. 5 of those, which is about 1/3 of the region's entire surgical throughput capacity for the only level 4 hospital in the area. Of the 16 operating theatres in Galway, 5 of them are now permanently closed. And the reason for that being given to me is that they aren't able to hire a relatively small number of theatre nurses. We know that agencies are paying at the 5th point on the scale for nurses, and they're paying an additional 20% on top of that. So agencies are paying, relative to a new entrant nurse into the public system, they're paying nearly 50% more to those nurses. The INMO, as I'm sure you're acutely aware, are balloting for strike action on Monday, which they're balloting to include work stoppages. Also, Minister, the INMO understands that a de facto moratorium on recruitment is now in place for the rest of this year due to the overrun budget constraints. They told me, for example, that 57 nurses were meant to be hired to help support patients on trolleys in the upcoming winter crisis, and they're now not being hired. So given all of that, Minister, my questions are as follows. First of all, do you accept that there is a crisis now in recruitment and retention, both for consultant posts and for nurses and midwives? The second question, Minister, is do you accept, if you do accept that there is a recruitment crisis, do you accept that the new entrant pay equality discrepancy is a major driver of that? Can I ask, why have talks not started with the Irish Hospital Consultants Associations? They represent over 90% of the consultants in the system, and they're saying that they have tried to meet with you, they've been trying to meet with officials for a year, and they can't get any meaningful engagement. Can I ask, why, for nurses and midwives haven't gone on strike in nearly 20 years. Can I ask, in the context of us spending more money than ever before on health, including huge overruns, how, in your opinion, has it been let get so bad for them that they've got to the point where they feel to ballot for strike action? And could you confirm whether or not there is indeed a de facto moratorium in place for hiring for the rest of this year? Thank you.
Thank you, Deputy Donnelly. Minister, thank you.
Thank you very much, Deputy Donnelly. I fully accept that the recruitment environment in the health service is very challenging. I fully accept that we operate within a global labour market now when it comes to an awful lot of these positions, both in relation to consultants but also actually in relation to nurses. Highly educated consultants from Ireland, highly educated nurses and midwives are sought after in other countries, and we operate very much in a global environment. I don't though accept your comments without a degree of context. Because if I was to take them without context, it would suggest that there's fewer consultants working in the Irish Health Service now, and that's not true. So there's 115 more consultants, extra consultants, working in the Irish Health Service this year than 12 months ago. So that does need to be acknowledged. Well, absolutely, I very much take your point, Deputy, in relation to there being much more to do and there being many vacant posts. That's beyond dispute. They're statements of fact. There are 115 more consultants working in the Irish Public Health Service in September 2018 than September 2017. Similarly, there are 523 more consultants working in the Irish Health Service in the past 5 years. So accepting that there are challenges, the number of doctors working in the Irish Health Service are increasing. Similarly for nurses, but I'll get to nurses in a moment. I do believe the issue of new entrant pay is one that needs to be examined, just like it has been examined across other elements of the public service. There is, in the Public Service Pay Commission, a structure which we set up, which, in fairness to your own party, I think you supported, to look at the issue of recruitment and retention. It made a number of suggestions, all of which have been accepted by government, but it also said that there should be a further process considered as to how the state and consultants could engage on the issue of new entrant pay. That decision is not one for me exclusively, it's one for me with colleagues across government, but it's one I would like to see advanced. The issue of consultants you referenced just Crumlin Hospital, and I'd be very happy to send you some information and perhaps send it to the committee in relation to this, because this perhaps suggests that pay is an issue but not the sole issue, and you're not suggesting it is the sole issue. I met the Children's Hospital Group very recently, and they were able to tell me that they're actually seeing a very significant increase in the number of people wanting to work as clinicians in our children's hospitals. And they're putting that down to, in part, the fact that there's going to be €1 billion investment in infrastructure that will give our clinicians more theatre space, better modern facilities, better research capacity, which is also, when I meet, as I do, with consultants, what they tell me as well, that yes, pay is an element, but also being able to see your patients, being able to ensure your patient has a bed, being able to ensure they have theatres are also elements as well. This issue of non-engagement with the IHCA isn't borne out by fact. My department was represented at their conference. There was ministerial representation at their conference. I know you, indeed, were at their conference. I'm very familiar with their issues. On the INMO, before you come back in, on the INMO, there is engagement going on today. I hope that we can find a way of resolving what is a brewing industrial relations dispute. But, and I think this is your own party's position too, not to speak for it, but parties to the pay agreement are parties that have undertaken not to submit new pay claims during the duration of that agreement. So the Public Service Stability Agreement, the parties to that agreement, have signed up to the terms and conditions of that agreement. The Public Service Pay Commission wants to see additional resources put in the pockets of nurses, be it in terms of allowances, be it in terms of the new entrant pay issue, and be it in terms of becoming a senior staff nurse at an earlier point in your career. So yes, there's much more we need to do in relation to supporting our nurses. One of those elements is financial remuneration. We asked the Public Service Pay Commission, not a bunch of politicians, we asked them to look at how do you fix recruitment and retention in nursing. They came back with a series of recommendations. The government's adopted the recommendations in full and wants to deliver on them in 2019. And in the budget architecture, your party and mine agreed, we have funded that. So I would like to have conversations and engagements with the INMO about other issues within the health service that could assist nurses in doing their jobs and support them in doing their jobs. And there are many other things which would be inappropriate for me to talk about in this forum because talks are ongoing. But there are other things other than pay that I'm sure could assist our nurses who are working in a challenging environment.
Thank you, Minister, for that. I'd like to come back. I know we've covered a lot of ground. I'd like to come back, if I could, to the specific questions, because we've both covered a lot of ground. The first is, do you accept that there is a crisis in recruitment and retention in either area, be it for nurses and midwives or for consultants? I think you have accepted that new entrant pay is a driver of challenges, whether you accept crisis or not. With regard to the Irish Hospital Consultants Association, the information I have, whilst I know you were meant to speak at their conference and Minister Daly stepped in, I'm not talking about public events. I'm talking about meaningful engagement. What they are telling me, and feel free to disagree with, they are telling me is they can't get meaningful engagement from you and from the department, and they haven't been able to get that for over a year. So can I ask, I believe there is a crisis. I believe that people are now suffering and indeed dying waiting to see doctors, and we are running out of doctors. And whilst the overall number may have gone up relative to the need, it's going down and down and down if 1 in 5 posts are now not filled. So can I ask you, given that, what do you propose to do? Because it feels like there's no action. It feels like we have a clearly identifiable problem, which is we are running out of specialists across a variety of areas, across a variety of hospitals, and it doesn't feel like those representing the consultants are being engaged with in any meaningful way. And just back to the nurses and midwives, yeah, I agree it's more than pay. There's lots of issues, but can I ask you, why has it got so bad now that for the first time in 20 years, what's your view on why they have become so frustrated and demoralised that they are now balloting for strike action, something they haven't considered doing in decades? Thank you.
Thank you, Deputy Donnelly.
Just to answer the last question, my understanding from INMO press statements and commentary around this is that the nurses are balloting for industrial action because they would like to lodge a pay claim. And whether, regardless of the validity of that pay claim, and it's not for me to assess people's motives, the Public Service Stability Agreement is clear in relation to pay claims during the duration of that agreement. So nurses believe they have a legitimate pay claim. The state has an infrastructure in which you deal with those things. I would hope that everybody uses the processes that are available to them. But there are clear mechanisms in place to resolve this, but there are also clear things that we want to do to help support our nurses. I accept the outcome of their ballot, fully accept their outcome of their ballot, which was conclusive, which was pretty definitive. But I also accept that the INMO are members of the Irish Congress of Trade Unions. I also accept that there are public service pay agreements in place. I also accept that the confidence and supply agreement that your party and mine are a party to commit us to supporting public service pay agreements, and it's within that infrastructure that I think we need to operate. So the nurses have decided to lodge I'm not sure they formally lodged a pay claim, but they've decided to ascertain the view that their pay should be increased, and that their pay should be increased in a sectoral specific way, without looking at the rest of the public service and indeed the knock-on effects of that. That's the position. I can't decide why the nurses have decided to do that. But I do accept that our nurses are working in a very challenging environment. I do accept that the recommendations of the Public Service Pay Commission, which would benefit many, many thousands of nurses, should be advanced as an absolute priority. And I do accept there's a lot more we need to do to help and support our nurses. I'm making the point that as Health Minister, I'd like to have that engagement about what we can do within the health service, separate to the process of public service pay agreements. In the issue of, look, whether I use the word crisis or challenge, I think, if you don't mind me saying so, is somewhat pedantic, because I don't believe me calling it a crisis helps or makes a difference. I think Mary Harney used to call things an emergency. Did it help? Did it make a difference? There's a real challenge. There's a very, very significant challenge in relation to recruiting consultants, and there's a challenge in relation to particularly the retention of our nurses and our midwives. The Public Service Pay Commission found that. What are we going to do? Well, I would suggest that we adopt in full, as we have, the findings of the Public Service Pay Commission. So they've made findings and recommendations. We should get on with them. We've committed to doing that. We've funded to do that in 2019. I also think we need to explore how we establish that process to look at the new entrant pay issue, which again is not an issue exclusively within my remit, but one which I take a very active interest in and a partial responsibility for. I do think there are other things that we can do. You said, what are you going to do to help? So in addition to that, the other things that we can do to help do include things like increasing theatre capacity, building elective-only hospitals, providing more bed capacity, because what we have found is when we invest in the physical infrastructure of our health service, when we provide our doctors and our nurses with the tools and resources to do their jobs, they respond in kind in terms of wanting jobs in that sort of health service. And we're very much seeing that now in relation to the Children's Hospital Group, and I will send information to the committee to that effect, showing the point that I'm making. I do just have to come back on this issue of, and I won't get into a back and forth on it here, but engagement with consultant representative bodies. Firstly, there's more than one body that represents consultants. That's just a point. Some consultants are members of the IMO, some consultants are members of the IHCA. Neither are unions, as they remind me, that consultants have individual contracts with our health service. We spent a huge amount of time, rightly so, as a department in recent months, along with colleagues in the Department of Public Expenditure and Reform, in resolving a major issue regarding consultants and the fulfilling of their contract. A contract that had, in their view, not been fulfilled or honoured in many years. I think it was Mary Harney was the Minister for Health at the time. It went right through until we actually resolved it this time. That obviously had a significant cost for the state, but it was the right thing to do. So this idea that there hasn't been meaningful engagement, we took what was probably the most challenging issue faced and being put forward by the IHCA and endeavoured to and successfully resolved it in recent months.
Thank you, Minister.
Very quick
one more, yes.
follow-up. Thanks, Chair. Mr. Conahan, can I ask you, as the acting DG for the HSC, the example I gave of Galway University Hospital, having a third of its operating theatres shut because they can't hire a handful of theatre nurses. And I have other examples right across the system of hospitals incurring massive fixed costs, incurring all the costs of opening a hospital, running a hospital, staffing a hospital, and for a very, very small amount of money relative to the budgets, are having huge detrimental effect on patients and indeed on doctors, who are getting increasingly frustrated that they come in on a Monday and the theatre is closed and patients are brought in the night before. They go through pre-op, they're ready to go in and they say, sorry, we don't have it. Can I ask, how is it happening that people like us can meet people working in hospitals and find these things out, and the HSC is not identifying these issues and definitively dealing with them? That's a question I have for you. Minister, one follow-up question on a separate issue, but it's a short one. It's on Justice Kelly's findings. Yeah. You and I have been going back and forth in correspondence, and you have pointed out that the HSC is reviewing its own recruitment and that indeed you would look at the individual case. There was an additional ask that I had, and apologies if you have come back, I haven't seen a response yet. Okay. And it's that, given that Justice Kelly has stated that there are wholly unsuitable persons working as doctors in our system, and he said that medical practitioners with little knowledge of the basics of medicine have been recruited to Irish hospitals, and is very understandably saying they pose a danger to patients. An ask I have of you is that you, stroke the department, stroke the HSE, whoever it is, would immediately conduct an audit. Because if we have doctors, whether it's 5 doctors or 50 doctors, walking around the Irish healthcare system with little knowledge of the basics of medicine, I would say we need to find out who they are. And it's not about kind of attacking them or anything like that, but there is a patient protection issue here. If such a senior justice in the country has said this, will you undertake to do an audit or to commission an audit as a matter of urgency to find out not only how it's happening, but where these doctors are, if they currently pose a danger, if we can help them, for example, through additional training, but protect patients if patients need protecting from people who don't understand medicine. And indeed possibly look back at case history to see if there are clusters of malpractice or patient safety incidences attached to doctors who may have little knowledge of the basics of medicine. Thank you. Thank you, Chair.
To conclude, Minister.
Can I just start on this? I'd like Dr. Colm Henry, as the Chief Clinical Officer, to come in a moment, but just to directly answer your question, because I did undertake to, and I have personally reviewed the situation here, which is something I wouldn't normally do, but in light of the significant comments of Mr. Justice Peter Kelly and indeed your own correspondence to me, Deputy Donnelly, I did write to the Director General asking for an urgent response. I did receive a very significant amount of information, which I don't feel appropriate to share in a public forum about one said individual. But it has provided to me information and assurance of a system that is largely, I want to decouple what I'm going to say here, but a system that took very swift action when an issue came to light. A doctor who was working in a hospital for a very short number of days, under supervision at all times, at a very junior level. The proper procedures were followed very quickly, and that doctor, obviously, and we know where that ended up in terms of the medical council complaint. So I do think, and I do want to say this to people watching in, and to people using our health services today, and indeed to doctors in our health service today. You know, we have almost 23,000 doctors registered with the medical council. In the last year for which there were available figures, 2017, I think we had about 300 complaints, and we had about 3 doctors struck off the medical register. So the idea that there is a widespread issue of doctors who I've heard referred to as rogue doctors wandering around our hospitals isn't borne out by evidence. There is an issue, though, and Justice Kelly rightly highlighted, and you've rightly highlighted it, Deputy Donnelly, in relation to our recruitment process and making sure that there's learnings from this case. But I can assure you that in terms of the composition of the interview board here, in terms of references being sought, in terms of a scoring technique, that all of the proper procedures were followed. This was a doctor who was placed on a panel, he was called to fill a post, he was supervised at all times, and when it became clear that he still lacked the competencies that would have been required in this situation, very swift action was taken. So what I think is genuinely the appropriate thing for me to do is twofold. Firstly, written to the HSE, which I've done, I've now received that correspondence back, to consider that in full, to also consider the process that the HSE might outline now, but that they're undergoing in relation to reforming the recruitment model. And secondly, to meet with the Medical Council, which I have now scheduled to meet them. I'll confirm the date with you, but it's very shortly, meeting with the Medical Council specifically on this issue, because they too have highlighted their concerns to the HSE. So there's an issue we need to fix here in relation to the recruitment process, not just in relation to this, but also actually in relation to, in general, streamlining our recruitment processes. I think to, and I very much accept your bona fides on this. I don't believe this is what you wish to do. But I think to announce some sort of widespread audit into this situation would cause undue concern, would be a disproportionate thing to do. I very much welcome the IMO's comments in this regard as well at the weekend. I think the appropriate thing to do is to review the case, which I've done, to make sure that learning is applied across the HSE and the recruitment model is reformed, and to meet the Medical Council. And if after that I believe there's further action, I will take it. If required, I will take it. But it might be useful to hear from Dr. Colm Henry as the Chief Clinical Officer of the HSE on this matter.
Thank you, Minister. Thank you, Deputy. Just briefly, it's important through your question, Deputy, to be able to assure public out there who might have concerns arising from this case. Of our complement of junior doctors in the system, we have about half of them are in training schemes, and they're recruited through training colleges, and there's a very solid, robust basis for that, and they're generally known to our system, having come in through our medical schools and worked in our hospital system with references from people we know. We have a dependency on non-training doctors arising out of the EWTD compliance some years ago, and all junior doctors, and I say this from personal experience, undergo mentoring and supervision appropriate not just to their level but to their background. In this case, while we can't go into too much detail about the case, it highlights how effective I think the mentoring and supervision can be. The interview is one part of a process. You can't validate everybody's background and entire knowledge and experience based on a half-hour interview, no matter how thorough that might be. But if you have concerns, if they've come, for example, from a medical school you're not familiar with and have references from people you don't know, you will watch them very closely, because no senior doctor, i.e. consultant, can afford to take risks when it comes to patient safety. So this particular case, to me, is unusual. But it highlights, it certainly highlights how effective the mentoring and supervision was, in that the concerns were brought to light very quickly before there was any contact with patients.
Thank you, Dr. Henry. So I'm going
just
to have to move on.
Comment from Mr. Conlon. It's just the last outstanding bit, if I could, Chair. Is that all right? Thanks.
So, very quickly, I do agree that if we've got facilities available, then the marginal cost of bringing these on has to be considered. It's rational. It's a good thing to do. Just one wider thing. Not just theatres we need to consider. We need to consider if we've got the staff. Okay, we've just had that conversation. Do we have the beds? Do we have the diagnostics to be able to back that up? So it's not just taking a look at theatres. But I would assure you that we have got excellent oversight on this. We have a National Performance Oversight Group which goes into the absolute detail of all of this on a monthly basis. You can hear more about that if you want from Anna Connor. And we also have the substructure beneath this, which is hospital groups and hospital chief execs that know precisely where they are in terms of the facilities that they could bring on stream if they had everything that was able to be put together to bring that on stream.
Thank you very much, Mr. Connaughton and Deputy Donnelly. Thank you. Deputy Louise O'Reilly.
Thanks, Chair. Just very briefly clear up a few things. And Deputy Donnelly referred to nurses' strikes 20 years or more ago. The last nurses' strike that I was involved in was in 2009. That was in Sligo. There was one in the University of Limerick that year, and then there was an all-out national strike as well. At the same time, and I know I'm sitting across from people who will, I'm sure, fondly remember those times. With regard to the national wage agreement, and I do love the way that it's always selectively quoted, and I loved it when I was a union official as well. There is a clause in the agreement, Minister, and you'll be aware of this, if only because I've told you about it several times, but I know also those other people will be aware of it, that says that the parties reserve the right to return to renegotiate the agreement in the event that circumstances changed. And when circumstances changed several years ago, nurses, midwives and every other worker in the health service, including the people sitting opposite me, will be well aware, when circumstances changed, those agreements were renegotiated to facilitate a cut in pay. So, you know, no agreement is immune from renegotiation, as I was oft told when they wanted to renegotiate the agreements. But that's just by way of information. With regard to my questions, the area of home care packages, and I would like to hear some comfort on this from you, if I could. There was a lady on the radio yesterday by the name of Margaret O'Reilly. She is a double amputee and she's waiting on home care and home care support. Okay, so the assertion has been made by her and by others, some working within the health service, some to us on a confidential basis, that effectively the money is gone, the budget is spent, and there's no more money for home care packages between now and the end of the year. And I would be very grateful if you could confirm or deny that, because it does seem to be the practice, and that is what we are hearing from people. Not only are they not getting enough in terms of the number of allocated hours, and you know, we could be all day arguing, are you ever going to get enough hours, but the actual fact that what I'm hearing, and some of this is anecdotal, and I have put in PQs to get to the bottom of it, but perhaps you could confirm it's either true or it's not, but what we are being told is that there is an effective ban on additional home care packages because the money has run out. With regard to recruitment and retention, pay is central to the issue, and I just refer you to the words of Philny Hay, who's the General Secretary at this committee. She was disputing something that was said by Deputy Donnelly, but that's actually not what I want to refer to. I want to refer to Irish nurses are not well paid by comparison. We have international comparisons that are compiled not by us but by the International Council of Nurses affiliated to the World Health Organization. They indicate that out of the 9 main countries that are English speaking with Western medical styles, Ireland's pay is the lowest, and that's borne out in the fact that nurses are graduating and leaving. Pay has to be central to it. But with regard to the recruitment and retention crisis, and Mr Mulvaney, you and I have spoken about this previously, the conversion of agency staff into directly employed staff. Are there targets? If there are targets, are you hitting them? Is there money saving target? Is it a personnel saving? How is it being quantified? And can you give us a figure for what targets have been allocated for this year? Have they been hit? What are going to be allocated for next year? And have those targets been hit? With regard to consultants who are not on the specialist register but are being paid as consultants, and it references an issue that was raised earlier, and I asked this of Rosarie of Miss Mannion when she was here previously. How many of them are there? Like, you have to know. So, as we're sitting here today, there's X number of consultants on the specialist register who are on a daily basis getting closer to an entitlement to a contract of indefinite duration. How many are there? And what is being done to, not to supervise them, but what is being done to ensure that they get the qualifications that mean that they can be added to the specialist register? With regard to the comments of Taoiseach about the holidays, and we did refer to this earlier, there was a specific reference made. There was a reference made to nurses and doctors, by the way, and I do think that that was offensive, but I think that because they were offended, not because I'm personally offended by any of it. But anyway, but with regard to access to diagnostics, would it be true to say that the issue is staff, not the willingness of staff to work out of hours? And my understanding is there's an agreement in place going back to T16, so that was what, 2006, 2005, towards 2016. There's an agreement in place there, section 39.6 or 39.8, or one of the sections in it referred specifically to the operation of out of hours, and that's 13 years ago. So I don't think that there is a problem getting staff to work those hours. I think there's a problem with the actual staff numbers, and you might be able to comment on that. And just one very, very quick question on cervical check. And maybe I said this wrong, Mr McCallion. What Mr O'Carroll is saying is that there was no on-site audit conducted in the outsourced laboratories. So I don't know what the difference between a visit and an on-site audit is, and obviously you will know that, and maybe you can confirm that that on-site audit either did or didn't take place in every single place where a woman who is availing of that service would potentially have the slide examined. Thank you, Chair.
Minister, thank you.
I'd start on I just want to make a comment on cervical check and also on the nursing issue. So just on the issue, Deputy O'Reilly, you didn't raise it directly, but it just reminded me to bring it up. I've seen in recent weeks an assertion that I, as the Minister of the Day, should call in HICWA to look at some of the situations in relation to cervical check. And I do just need to remind the Oireachtas that that was my initial starting point when cervical check, when the cervical check debacle began, that I was proposing a HICWA statutory investigation, that HICWA would have all of the powers that entailed to investigate all of these matters. And the Oireachtas, and I must say quite rightly, I think this is where engagement actually really does work. The Oireachtas said, no, actually we think, considering the circumstances, you actually should bring in someone external, possibly someone from outside the jurisdiction, and that was Dr. Scally, and he obviously did that piece of work. So, Mr McCallion will come back on your specific question, but I did just want to take the opportunity to say that here today. The issue of the nurses' dispute, just to bring the committee up to date, this has literally just happened in the last few minutes, but as I said, there was engagement today with the INMO, and at that engagement, the view was put forward by the employer that the pay claim cannot be processed within the terms of the current pay agreement. Obviously, as Deputy O'Reilly, with both her current and former hats, outlines, the union has a different view in relation to that.
Says something different. It says both of the things that you and I are saying, but it does say both of those
The next
things.
line might be the real closer on this, because when two sides to a dispute have a different view in relation to whether a claim can or cannot be processed, the appropriate thing to do is to refer it to the oversight body that was established to oversee that agreement. So that's what we now intend to do, to refer the complaint and the claim to the oversight body. I think that's the appropriate vehicle to do that, and I would hope and would ask that both sides to this dispute would engage fully with that, but also that people would reflect on the prudence of balloting for industrial action when there is an oversight body going to consider this matter. I think that would be the appropriate thing to do, to let the oversight body do its job, and let's see what the oversight body has to say. I do also have to make the point that the Department of Public Expenditure and Reform did cost, and in recent days comment on the cost of funding the claim put forward by the INMO, and they've costed that at €300 million a year. So it is a very sizable sum of money that we're talking about here, and it is one that, if people wish to deviate from the public sector pay agreement, in terms of if politicians wish to suggest that, one that I think people have to say how they'd actually fund, because €300 million is obviously a substantial sum. But look, I hope that engagement can take place, and I think the oversight body is the appropriate body to do that in. On the issue of home help, I think you've asked the HSE to comment on that, and I'm happy for them to do so, but I do want to make the point, from a policy perspective, the development of a statutory home care scheme is acutely needed. I think you know that. I think we're all in agreement in relation to that, and Minister Daly, who's had to leave, is doing a huge body of work with the department on that. We are yet again increasing funding for home help, and we're not just waiting till budget 2019 delivers a service plan. We're actually going to do it as part of our winter plans as well. So you are right, there are certain areas in the country particularly that have seen an acuity on this matter in recent weeks and months, and I hope that we'll be in a position to rectify that now. And I might ask John Anne might perhaps comment on that, or
Okay.
English comment first.
Yeah, thank you. I'm going to ask Dr Henry to say a word or two about the consultants and the specialist register, and Anna Connor to say something about home care packages. But just before Dr Henry speaks, I think our ambition should be, in relation to consultants not in the specialist register, during the course of 2019, because they all have different circumstances in terms of where they are around training and seniority and previous experience. Each one of those really needs a development plan, a personal development plan, PDP, to say this is what we're going to do to be able to support you to eventually get on that register. That is a good thing. It recognises the previous work, good work we've done in Ireland, but also recognises what we need to do for personal support, individually tailored to that individual. Dr Henry.
Thank you, Deputy, for your question. We have, if we could divide them into two groups, the consultants and the specialist register, those before 2008, when there wasn't a criteria of appointment, and before the Medical Practitioners Act, and there's approximately 50... My question
specifically about the contract of indefinite duration. So those people, the pre-08 people, they've already got it.
Yes.
I mean, time was on their side with that.
The reason I say that, Deputy, is because that particular condition didn't apply at the time.
Yeah.
So there was 50 of those, and they're well within the system, as you point out, and well established as practitioners. So we are choosing not to, if you like, address their particular issues. The issue, really, your question is directed at those after 2008, when it was, and we have a figure of about 100. I'll get you the exact figure, who are not in the specialist register. And what we're doing is we're making visits site to site, and there's two particular sites these consultants work on. One is acute hospital sites, and the second in community healthcare organisations as psychiatrists. As the Director General just pointed out, there will be individual needs for each one, individual deficits, and we have to. We're working with the colleges to see if we can address what deficits in either training is required in order to allow them to be adopted onto the specialist register, to give the public the assurance they need that these people are working and practising as bona fide consultants.
And have they all got the personal development plan? There's a personal development plan?
Well, each one, our aim is that there will be a personal development plan for each one of those cases to allow them to come out to be adopted.
And how many of them have it now?
Well, I can't give you those figures yet, because the visits to the sites is ongoing, Deputy, but I'll come back to you with a further report.
There doesn't seem to be much urgency on this now, and I think it is a pretty urgent matter. Sorry, Chair, I know I'm having all the time.
Just give you a bit more on that. I think it's true to say that in terms of where we started to engage in personal development plans, it was only in this autumn. I did say that I would expect that throughout the course of 2019 that we get there, but there will have to be an individually tailored conversation with each of those members of staff to be able to achieve that. And that's not going to happen overnight, but during the course of 2019. We will try to do it as quickly as we can during 2019.
Thank you.
Okay.
Thank you, Deputy O'Reilly. Sorry, did you want to make a comment? Sorry, Mr McCallion.
Just to close off the Deputy's question on the on-site audit. I suspect what's referred to there, Deputy, was the quality assurance standard for the programme. Required or requested that there would be a site visit every 3 years for audit purposes. I believe the last one was in 2014, and there was one scheduled in 17 that didn't happen. Dr Scally has obviously done a site visit this year to all of the laboratories to review it, and our intention as part of the revised QA guidelines is to commence those again in 2019.
Home care, yeah, also the diagnostic staffing as well.
Okay, so Deputy, you've rightly recognised that there are challenges on the home care front. I didn't hear about the case that you referenced or which part of the country that was in.
In Dublin.
In Dublin, yeah. In relation to home care, we are funded this year to deliver about 17.3 million hours of home care. And we are on target to deliver that in all areas. In reality, I'm going to say overachieving the target, which isn't necessarily a good thing in this case.
Depends on whether you're waiting for home care, I suppose.
It's not something that we should aim for. But I think the challenge is particularly prevalent in Dublin. So when you look at the Dublin hospitals, and we are prioritising home care to support people to come out of hospitals, and we currently have, as a result, about 6,000 people in the community awaiting home care. So what we have seen throughout this year is an unrelenting demand in terms of services like this. It hasn't abated in the summertime as it might have previously. And we have a demand. So as the Minister has said, we are looking at enhancing home care now. We'll be putting in excess of 300 additional packages in December, and we will also be putting additional packages in the early part of next year. So we are hoping that that will make a difference. But certainly the statutory scheme will also be welcome. But I think home care, and when you look at what Sláinte Care is advocating, home care is a critical part of how we need to deliver our health services. So we are looking at that.
Thank you very much, Ms O'Connor. Thank you. So before we go to... Sorry, did you wish to...
Diagnostics over Christmas.
One of my colleagues might cover the diagnostics, I'll cover the agency if I can. So you're asking about conversion targets, Deputy. So in setting the WT limits to year end, and I was trying to find them here for each of our national entities, we've set a target or a limit for agency conversion across all levels of agency. So we're saying to people, if you can convert agency or indeed overtime in real net terms based on where you were at June, that's an acceptable.
From June.
That's an acceptable growth in WTEs, because we are trying to drive down the level of reliance, particularly on agency, not just for cost but also for service reasons, as we said earlier on. So while there's a limit there as to how much net additional growth we'll accept for somebody saying that explains my increase in WTEs, if someone goes over that and can demonstrate that they've actually brought in more people and sustainably dropped the agency, that's not that we don't see it as an issue.
And is it done on a hospital by hospital basis or
like
area by area? How's it
like
calculated?
all the WT limits, Deputy, we've set them out at our, let's say, acute operations and community operations level, and then they've allocated them out to hospital group and community healthcare organisations, and it'll go from hospital group then to individual hospitals.
Okay.
But the main message is if people can sustainably reduce agency by conversion below that June level, we would see that as a positive thing. It assists overall.
And can you share that information with us with regard to the targets?
We can, I can certainly see what part of that we can share with you. I'll discuss
It
it with
shouldn't
my
be a
colleagues.
secret.
And before I bring in Deputy Murphy, who's the next contributor, Minister, just to go back to some comments that Senator Burke made in relation to a new GP contract. And we have spoken about this before. The Programme for Partnership Government proposes that there would be a new GP contract negotiated. But what's actually happening is we're not negotiating a new GP contract. There is a manpower shortage in general practice, a huge manpower shortage in general practice, and that is demonstrated by the fact that GPs are now closing their lists of new patients, because it's the only way that they can control the amount of work that they're doing. New work coming down their way, and also new work being transferred from the hospital service back into general practice. There are many vacant posts in general practice, another illustration of the manpower crisis. Not only public contracts, GMS posts, but also GPs who have difficulty recruiting assistants and partners within their practice. GPs are emigrating because of the quality of the service that they are feeding into, because they cannot get access to services for their patients, and they have great difficulty getting access to diagnostics. So for all those reasons, there's a huge manpower crisis. Now, the government has chosen not to reverse FEMPI for general practitioners. It has chosen to go down a different route, and you've outlined it this morning: sustainability, expansion of services and expansion of eligibility, which may, in some future date, feed into the negotiations of a new GP contract. I would contend that the negotiations of a new GP contract should be parallel to what you're doing at the moment. I would also contend that the government should reverse FEMPI. However, you have set your direction differently. So the question I'm asking you is, how can you implement Sláintecare, which is founded on the transfer of services from hospital-based services to primary and community care-based services, if you don't have the GP manpower to do that? And the only way you will get the GP manpower to do that is to develop a new GP contract. You can add things to the existing contract, which is what your policy is at the moment. You're adding new services and you're expanding eligibility. But you cannot do that without expanding the manpower in general practice. And the only way to do that is a new GP contract. So the question, Minister, is when are you going to start negotiations on a new GP contract?
Thanks very much, Chairman, and I know we've discussed this quite a lot. I do need to say at the outset, every single element of what we are engaging with the IMO on now is pointed towards Sláintecare. So Sláintecare is the singular test in all of the asks that we on the state side have in terms of the engagement with GPs. So when I talk about, and I don't wish to negotiate in public because I'll be in awful trouble if I do, but when I talk about sustainability measures, I'm talking about making general practice sustainable so it can deliver general practice and deliver Sláintecare rather through general practice. I'm talking about making sure that there are going to be enough GPs who say, yeah, this is a challenging but actually rewarding career that I can manage to do and want to do into the future. So the sustainability element of what are three elements of these talks does look about exactly what you say. How do we ensure that there's enough people who will come into general practice, who will stay in general practice? And I think that's a key element. The other two elements on access/eligibility and on chronic disease management are directly focused at delivering Sláintecare, taking services that are today provided in the hospitals and providing them in the community in general practice in the future. And the eligibility piece, again, recognising that if we don't support general practice, they can't do this, but if we don't do this, we're going to end up with a situation whereby people continue to end up in the hospital setting far too late in the development of their illness because perhaps cost has been a barrier within primary care. And we saw the recent report in relation to primary care and the lack of universal access here and how that compares unfavourably to other countries. So whilst we're not going to have a big bang new contract, and I accept that charge, if I may put it like that, or that assertion that you're making, what we are going to have is a framework that is going to deliver a number of new and exciting services, but that is also going to invest in general practice, recognising that it needs to be sustainable. So when I hear, you didn't say this, Chairman, but when I hear others say it, that all of the money that the government wants to invest in general practice is for new services, that's not right. Because we recognise as a government that before you ask people to take on new services, by the way, that you and I know GPs want to take on, but only if they're supported to do so. But before you get to that piece, you have to make sure, is the current service sustainable? And I accept that after years of FEMPI cuts, that has brought us to a position where general practice needs support to stabilise it. So there won't be a big bang contract moment, I concede that, by the end of the year. There will be, though, significant investment in general practice. There will be a multi-annual framework for that investment and for the rollout of services. And that framework will help us continue to develop and evolve and modernise the GP contract. This is we're talking about a period of 4 years here in terms of what we're discussing at the moment. But what we're also trying to do, and again, I can't go too far in this in public, what we're also trying to do is make sure that we don't conclude these talks at Christmas and say, that's it, we're done, we've delivered a GP contract or we've reformed the GP contract, but that it's part of an ongoing evolution, that there'll be more things that we want to talk to and more changes that we want to bring about into the future. So it is very much about getting a framework in place. And I think when members of this committee, subject to us getting agreement, see what we're trying to do, I think you'll see much in it that you'll like.
the point I'm making, Minister, is that if you're building on a contract that's 45 years out of date, I shouldn't say out of date, it's a 45-year-old contract.
Yes.
If that's the foundation on which you're building, yes, that may make some practices sustainable. It may allow them to continue to operate, but it's not going to attract any new GPs into the service, because the fundamental basis on which the contract is built on is out of date. So you're putting structures on a contract which is actually unsustainable itself.
Sure, and I take that point, Deputy. I think, or Chairman, I think the thing to remember, though, is by the end of this framework period, that old contract will effectively have been replaced. So this is an evolving period whereby we invest in sustainability, we invest in new measures. And I do think, and you've talked to me about this and indeed educated me from the perspective of a GP about this too. I mean, one of the things that a lot of new younger doctors want to do is provide kind of new and exciting services and work in different ways. And we are talking very much about both of those elements as part of the talks now. And I hope to be in a position to share this with you, because we've been talking about this for a long time at this committee. It's an urgent issue. By Christmas, I hope to have this resolved.
Minister, thank you. Deputy Murphy.
Chair, and welcome in, Minister. I'm actually spending more time with you in the last week than I am with my husband, so we might get tongues wagging. Apologies if some of these have been covered already, but I had to go on the plinth. Minister, can I ask you please for a comment on the Ombudsman's his own comments this morning on the learning to get better, and about the recommendations not being implemented. So, as you know, the HSE accepted 36, 10 fully implemented, 17 partially, and the other 9 either not implemented or still being considered. So I'd like your comments on that, please. Also, Minister, Reprisa, just wondering if there's any update on that, please. And also Freestyle Libre. I know that this has come up many times before, but I have been contacted a lot more lately than previously about people who this, you know, if this was reimbursed, it would change their lives. Obviously, none of us would like to be prickling our finger every day. Sometimes people have to do it up to 10 times a day, and it is causing a lot of pain. So it would make a huge difference to the 20,000 adults, and I think it's not a huge it wouldn't be at a huge cost financially. So I would really recommend that these people will be looked after. And can I also ask you to confirm, I know the 4 to 21-year-olds are covered, but when a person reaches 21 and further, are they going to be covered, you know, into the future? And obviously that would be good, because eventually then everybody, if this continues on, everyone will eventually be covered. But at the moment, there are a lot of people enduring a lot of pain every day. And I know this is Minister McGrath's remit, but unfortunately he's not here today. I just want to highlight to you, Minister, the huge waiting list still for the assessment of need, and after that, then the huge waiting list again for the therapies that are recommended in the assessment. And Cork, for some reason, seems to be particularly badly hit, and I suppose we are finding it hard to get to the cause of that. But just to highlight the seriousness of that to you, Minister, please. Thank you.
Thank you, Deputy Murphy. Minister.
Thanks, Chairman. I might share out the questions if that's okay, Deputy, but just to take 2 of them. The assessment of needs, you're right to highlight this issue, and I know you've been highlighting it for quite a period of time. And O'Connor might like to add further detail, but from my perspective, the fact that we've allocated, indeed in engagement and negotiation with yourselves, funding for 100 additional therapy posts in 2019, along with some of the work the HSE are doing in terms of reforming assessment of need processes, I think will make a real and meaningful difference. We'll obviously be cognizant through the service planning process of allocating them to areas of particular and specific needs, so not to do the service plan here, but areas where there's particular acute problems, and you've referenced the area of Cork. That'll obviously be factored in as we work out where to allocate those 100 additional therapy posts in 2019. On the issue of Reprisa, I'm glad you brought this up, and Deputy Kelly, I know brought it up before I was here as well, but I caught a little bit of what he said. there is two issues here, I suppose. There's the issue of the general reimbursement of the drug, which I'm going to put to one side because that's a matter for the drug company to put in an application and go through the legal reimbursement process that the HSE has responsibility for. But there's another issue, and a more acute issue in my view, and an ethical issue in my view also, that there are about 19 patients who were on what was a very long, in my view, a very long-term kind of compassionate access programme, clinical trial type programme. That support was pulled from them very quickly. I don't think it was handled very well by the company. They know my views in relation to that. The HSE has been engaging very intensively to try and provide a certainty for those 19 people. And I'm very confident that in the next few days that the HSE will bring that to conclusion. And I want to thank them for the very hard work that they've been doing on that. They've also taken the unusual but appropriate step of actually providing some of the costs of administering the drug through nurses and the likes in the interim period. So I am very hopeful for a resolution for those 19 people in the coming days. And I choose the word days. Yeah. On the issue of Freestyle Libre, matter for the HSE's reimbursement process, so they may wish to comment, but I know at the moment it is, as you rightly say, available to children in hospitals. I think it's currently about 6 months through a 12-month evaluation process, so we may, if we don't have the information here, we may come back to you with a note on it. I think there's a question in for answer on it today as well. And on the issue of the Ombudsman, I think it's appropriate that the Director General would respond, as it was a report to the HSE. Like you, I noted that there were a number of areas where the Ombudsman welcomed significant progress, others where there's still work to do, so the HSE may outline to the committee where they're at in that regard.
Okay, thank you. I'll maybe bring Colin Henry in to say a word or two about the complaint system, but before I do so, okay, can I just give you some facts and figures? Over the past 3 years, we have now built up the number of complaints officers to about 500. Okay, so that's really quite significant, and that's progress locally. But one thing that I think should be in our ambition, as well as pursuing some of the process issues that have been outlined in his latest report, I think we should do something to get more upstream of complaints, and that is to stop a complaint happening before it actually turns into something more serious. Okay. So I'll just say that as a general ambition, okay? And I've got some views on that I can expand on later, but Dr. Henry.
It's certainly a fundamental right for anybody who uses our service to voice their opinion, their concerns, their feedback, and of course their complaints. And we've recently completed our National Patient Experience Survey for the second year running in our acute hospital system, which I hope is testament to our absolute intent to listen carefully and to respond. With regards to the Ombudsman report, there's a lot of work we have done on this, and it needs highlighting. There's a lot of work we have to do, and of course that's highlighted in his report this morning. His own report, Learning to Get Better, is a really valuable platform for us to build our review of our current complaints process. Your service, your say, we carried out that review in 2017. Also how we develop an advocacy framework with the Department of Health, which we're doing at the moment, and also to show that we learn. We've developed a complaints management system online with the State Claims Agency. The Ombudsman did criticise the rollout of that, and we'll have to take that on board. And working with the Ombudsman, we've developed an e-learning framework to help those people who are managing complaints in our CHOs and hospital groups to manage them more effectively, supporting both patients and service users, and supporting our staff who are supposed to be listening and responding to complaints. So we are working with the Ombudsman, and we intend to fully implement the recommendations of his report, and to make our more in 2019, and to make our system more responsive to people who use our services wherever they may present.
Thank you, Doctor.
Thank you, Dr. Henry.
On to that. So assessment of need, as you've said, has been a challenge for a number of years now. However, a couple of things have happened. So this year we have had to date just under 3,800 applications, which is actually down considerably on last year. We believe that this is linked to the new model of resource allocation in schools. So we are down at this time over 700 applications. We expect that to be down to up to about 900 by the end of the year. However, having said that, we also have had to undertake a significant programme of improvement, and that's linked to a couple of key things. One has been to approve a standard operating procedure for assessment of need. That has, I suppose, led us into considerable negotiation with staff groups. We hope to have that resolved in December, and we will have a standardised approach to assessment, because it has been variable around the country.
Things going on with that, yeah.
Yeah, and that's nearly concluded. The other really important thing is that we've been looking to develop children's disability networks, which will really improve all sorts sorts of services, not just assessment of need for children with disabilities. Just this week, we have now concluded that, and we have reached agreement through a mediated process, and we're now going to be advertising those network manager posts. So we will have 87 children's disability networks, and we will have network managers whose sole job is to focus on the coordination of services for children with disabilities. The other thing, just in relation to CHO4, so the Cork Kerry area has been the most challenged in terms of the numbers. They've undertaken a significant programme of improvement this year, and whilst they're not out of the woods yet, they have seen their numbers drop from in excess of 1,700 in Q1 down to just under 1,200 now. So they are improving. They still have a way to go, but there's a lot of work underway.
Thank you.
Okay. Thank you, Deputy
Thank
Murphy.
you, Chair.
And Ms O'Connor, while you're metaphorically on your feet, I had a question which I put to you in relation to why the winter initiative this year has been so late in being announced. Surely we would have expected it to be announced a long time before the winter. So perhaps you would refer to that.
Okay. So I think in terms of the planning for winter, that actually started at the end of last winter, and we looked at a couple of key things. So in terms of capacity and improvement, in the first half of this year we were focused on developing a 3-year plan which would look at improving capacity, because I think, as Deputy O'Reilly or Deputy Murphy said earlier on, you know, we shouldn't be surprised by winter. We know it's coming every year, so we have to look at how we can develop our capacity in line with that, and also looking at how our services can improve. So we have an improvement initiative called the 5 Fundamentals underway now that's been peer reviewed and has been piloted in the South. So that work has been going on all year, and that then led us into September. Another important learning point for us this year was the Pikeville visit, which actually we examined that in terms of what worked around that, our response to setting that up, and that has led us into a slightly different approach this year. We are working with colleagues around the country who have emergency management experience, really, in terms of national and local coordination teams, and we are looking at how we can maximise what we have available to us. So, as I said earlier, we haven't published the report. We're in discussions with the department. They've pretty much concluded in terms of our approach and agreement around how we're doing this, but that has not prevented us from starting the work. So we have been engaging with services since September. We have integrated plans from all areas. We have a plan that we have now agreed. We are now finalising the areas for investment, but a lot of detailed discussions have been going on with services all around the country. And our challenge really, and our focus, has been on ensuring an integrated pathway for people throughout winter that really begins in primary care and tries to keep as many people away from emergency departments as possible. That's not to say that we won't be challenged, because the numbers are high now. They will be higher, but we have to look at maximising all of the supports available. So a lot of work has actually been going on since September on that.
Thank you. Now, Deputy Durkan, Senator Burke and Deputy Chambers. So, Deputy Durkan.
Thank you, Mr. Chairman. And I just to follow up with some of the previous questions as well, I want to welcome the progress indicated in relation to the carrying out of an audit to find out where the deficiencies are. I think that will bring fairly dramatic results, provided it's followed up. And there's not much sense identifying where the deficiencies are unless there's something done to progress them. And I realise that that's in the context of preparation for sláinte care, and I think that is most certainly to be welcomed. The question of emergency space in the event of there being an unforeseen demand during the winter period, is it possible to identify emergency space that may be needed in the event of there being a prolonged winter, or prolonged illnesses, or whatever the case may be? It's possible to do it everywhere, and including in hospitals. And just in terms of an emergency plan, there is it possible to do that in the context of staying within budgets and so on and so forth? The question about the unqualified doctors that have been reported. Surely the Medical Council have as stringent a system as other professionals have for dealing with these matters, and they're at least as well qualified as they are in other areas. Why doesn't it work? Why nobody should get through? I know other professions where the council governing the professional body lets nothing through. Unless they're fully and properly qualified. So I'd like some comment on that as to why that's not happening. The home care. The home care is obviously home care packages are in huge demand, I have said over the years, that home care doesn't come cheap. It doesn't come free either, nor was it ever expected that it would be that way. But there has been this anticipation created that it's a much less expensive way to deal with things. No, it's not, but it has to be done. It's part of the system. It's part of the jigsaw. And if it's not put in place, then some other part of the system will feel the brunt. I know that there's two other questions now, and one of them is a parochial one. I know I'm very loath to go parochial in these things, but I couldn't allow the situation to pass since all other hospitals virtually in the country have been mentioned already. I think it's no harm, just in case that the Minister and his staff and the HSE might think that Naas Hospital is not for mention in these circumstances. So I could mention it a couple of times, but I did have a topic issue on the subject last week, and I acknowledge the progress, but I want to emphasise, the new units, the proposed new units, are an urgent necessity for the operation of the hospital. And it is hugely important for the delivery of services to the catchment area that we accelerate that programme in the oncology and endoscopy units as quickly as we can in order to make the services available. And the last question, Mr. Chairman, is in relation to the degree to which the health services generally are prepared for and can cater for a major emergency. That's something that we haven't done in some years now, as far as I am aware. I know that in the last winter, I want to compliment the health services for the manner in which they dealt with the situations that arose then, and the sacrifices that were made, and the doubling up and the staying over of staff in the various levels in the various hospitals and so on, and the tremendous work that was done. But we could have even more serious emergencies than that. They are obvious from looking at international news. They arise on a daily basis, and we know not the kind of emergency. So the question is the extent to which we can now deal with a major natural or national disaster.
Deputy Durkan, thank you very much. Mr. Connaughton.
Okay, I'll deal with some of these and pass a few on if I could. First of all, your first point on flow and audit results. Okay, what I'd like to do is, if you don't mind, I'd like to send you the results of what's been achieved so far in some of the major flow programmes. That's what was happening last year, what's happening now, and has there been an improvement, of what learning have we got from it. So we'll send you that. Okay. Secondly, can I deal with the issues of emergency space and catering for a major emergency in the same answer, if I could? First of all, the experience in Ireland is that when we do have an emergency, whether it's snow or whether or not it's storms, okay, we actually cope tremendously well, and the experience of bouncing back from that is relatively quick. Okay? Now, a lot of that is to do with the flexibility that we have from staff in terms of being available at all hours, and indeed, as I said earlier, staying on site sometimes to be able to cope with the exigencies of the service. So the experience is actually quite good. In terms of flexing up for major emergencies, you'd probably be surprised to know that, or you won't be surprised to know that we've actually got through the year a number of major emergency exercises to prepare for things, whether it be a flu pandemic, terrorist attack or something else. And Mr McCallion, who used to be in charge of that section, can give you more colour on that if necessary. One thing from my experience is that some years ago in the flu pandemic in the UK, and this is no different from Ireland, we had a contingency plan which looked at the requirement to rapidly increase intensive care beds and respiratory facilities. And we did that by turning high dependency unit beds into intensive care unit beds, and we had a backstop which was, if push came to the shove, could we then use theatres for that kind of facility. And now thankfully it never came to that, but we do have these kind of plans available and laid out, which are in a series of escalation responses to any issue that might arise. So with that, can I maybe just turn over to the issues that you raised on the medical side to Colin Henry?
Thank you, Deputy. Regarding the Medical Council, I'm not here as the representative, but I'll answer as best I can the question you put to us. On the back of this case, I met the Medical Council provisionally yesterday. We're going to have further engagement with them over the next week or two to address the issues raised by this case. But my understanding is that the Irish Medical Council has we have a reciprocal agreement with other EU countries in this country, so there's no grounds for refusal of a doctor for registration based on their country of training, so long as it's in the EU. That said, we want to find out not just the learning from this case, but any learning the Irish Medical Council have from any other cases.
Mr. Chairman, sorry to interrupt. That is a departure now from the manner in which new drugs are examined, where even though we have an EU level for examining and approving new drugs, we do it ourselves as well. We raised that question at that time. So that really is a question that the Medical Council I don't accept that that is an adequate answer. I'm not blaming you for it, but it's a fact.
I'm just saying the facts here rather than an opinion. But as I said, just be careful what I say here. That they have no grounds for refusing somebody just based on the country of origin of their training, so long as that's in the EU. But that said, if there are any issues pertaining to patient safety, not just arising from this case, but any other cases that come to the attention of the Medical Council, clearly we'll have to review what's best for our healthcare system based on putting patients' interests first.
I'm a bit concerned about that, Mr. Chairman, because there's an inconsistency there. If on the one hand we are particularly careful and we double check in respect of drugs, as we should do in most cases, even though the same check is being already done by the European institutions, where we're also represented, incidentally. But we don't seem to apply the same principles in relation to staff and their qualifications, which it's at least as important as the drugs verification.
Just finally, Deputy, if I could, clearly we have our own registration process and our own registration rules, regulations, all underpinned by law. All I'm saying is that anyone who applies for registration in Ireland cannot be refused on the basis of their country of origin of training of registration, so long as it's in the EU. Not on that basis alone.
Thank you, Dr. Henry. There was a question that you had in relation to home care packages
and the space,
and Naas Hospital.
And Naas Hospital and the accommodation space to deal with the possible winter emergencies.
I think in terms of that, so the use of space, and as the DG referenced, we have escalation plans. Each hospital has their own escalation plan, and there is a point in that plan where they would use other space within the hospital if they could not cope with the numbers coming through. Now that would result in using space that might otherwise be used for elective care, etc. So there's obviously a balance to be struck in terms of how much of that activity you stop. But we are also challenged because sometimes we have numbers and significant numbers of people who require isolation due to infection. And then we have to consider the staffing of additional space. So we are at times challenged to staff what we have open all of the time. If we add more into the mix, it can create more challenges. In terms of home care, I think your point is noted, and I think maybe I covered it. Our waiting lists are considerable, and I think in the, certainly in CHO7, which would be an area relating to Naas and Talon, that they're particularly challenged. In terms of Naas, just to reassure you that Naas is one of the 9 sites of focus for us in the winter period, and it's named specifically in the winter plan. So it will be receiving significant attention as part of that.
Naas Hospital?
Yes.
That was it.
Naas, the next phase of the development plan, which is pending and needs to come into operation as soon as possible. And I raise it on the basis that it affects the general delivery of services and the morale within the hospital. You can only be so long waiting for something to happen.
Okay, I'll have to come back to you on that. I don't have the details as to where specifically Naas is at in terms of the development.
The Minister wants to answer that one, I think.
Because I visited Naas Hospital and met with the staff there, and I met with the Dublin Midlands Hospital Group, and I know it's a priority both for the hospital and the hospital group in terms of a capital project. It will make a huge difference to endoscopy waiting lists, not just for Naas Hospital but also for the entire Dublin Midlands group. This was a project that was ready to proceed when the economic crash happened, and I think it was very unfortunate that, as you and I remember when we visited there, Deputy Durkan, the hospital just lost out, if you like, as capital dried up during the economic recession. Now that we're back, with a much larger capital budget, €11 billion for the next 10 years compared to just over 4.9, I think, for the last 10. This will be a priority project where we're currently engaging with the HSE on finalising our capital plans for 2019, and it will be considered in that context.
Thank you.
So our last three contributors, in line of indicating Senator Burke, Deputy Chambers and Senator Conway. Walsh. Senator Burke.
Yeah, just very briefly, just on the winter plan. Nursing Homes Ireland advised me that they raised as far back as May, June, that they wanted to be very much involved in working with the HSE in relation to the winter plan. They wrote a letter on the 30th of September and they received a letter back on the 31st of October from the co-chair of the management team, advising that their proposals or their engagement would be discussed at the meeting in November. Now, I understand the meeting in November is the 26th of November. And one of the issues that they have raised with me is that, and they've said this happens every year, that from the 22nd of December to about the 3rd week in January, they have very little engagement with the HSE as regards working with them, as regards helping to relieve the numbers out of the hospitals. And they're a bit concerned that they have not been involved in the engagement to date in relation to the winter plan, and they are very anxious to be available and to work with the HSE so that any issue in relation to numbers in hospitals can be dealt with in an expeditious manner. So I'm just wondering, maybe I might get some comments on that, because they certainly want to work with the HSE in relation to this area. The second issue that I just want to go back on, and that's about the consultant contract and about trying to make it attractive for people to come back. And I know we've gone over the consultant contract a few times today, but I'm just wondering, you know, we put in a new system of salary scale and everything else over the last few years, which is not now working in a lot of areas, in the sense that and a number of other people have raised this issue. People are not attracted to the jobs and the skills that are being offered. And the point I raised earlier on was about the 110 million spent on agency, the employment of agency consultants. And I'm just wondering, is it being looked at from a department point of view and from a HSE point of view about reviewing that and how we can go forward? Because if you look at the whole, and someone else raised it earlier, about the retirement, the numbers of people that are going to retire out of the health service right across Europe. My understanding is that something like 1/3 of all medical consultants across Europe are over 60 years of age. So we're going to be facing a challenge, and I'm just wondering, in facing that challenge, we also need to be competitive as regards what we're offering. And I'm just wondering how we can deal with the issue, because I don't think we have been serious about dealing with this over the last 3 to 4 years. And I understand fully that there are other demands, but we need to have something attractive there to bring people in. And I'm just wondering, is it being looked at the moment, and is there likely to be some engagement with the consultant group in relation to this issue over the next 6 months?
Thank you, Senator Burke. Minister.
I can take all those issues in relation to Nursing Homes Ireland, and thank Senator Burke for bringing this to my attention in recent days as well. I've asked that the Department and the HSE will engage with Nursing Homes Ireland. I think you're right. Nursing homes have a very important role to play in winter planning. And I suppose one of the very important roles I think they have, from my perspective, in terms of looking at it from the patient's perspective, is ensuring that we can keep as many older people in a nursing home in what's perhaps a much more comfortable environment than an emergency department during a very busy period of time. So I look forward to that engagement between Nursing Homes Ireland and the HSE taking place. In relation to the issue of consultants, I suppose there's really two parts to that answer. The first is the one that I outlined to Deputy Donnelly earlier, which is the fact that the Public Service Pay Commission does talk about a process that should be considered at a point in time in terms of engaging on the issue of new entrant pay. And that's something that my own department will be considering with the Department of Public Expenditure and Reform in terms of how best to advance. But secondly, there's also the fact that we now have a Sláinte Care report. There's the fact that Donald de Butler's group is doing a very big body of work in relation to private practice in public hospitals and how do you set about decoupling the two in line with Sláinte Care. And there's no doubt that this is going to require at a point in time contractual engagement with consultants. So there's the monetary piece, if you like, in terms of what I've just outlined from the Public Service Pay Commission. But there's also the job spec piece. There's also how do we make sure that consultants, medics who want to deliver health reform are able to do it under their contract. So they're the two kind of big pieces of work we'll be working on in relation to consultants.
Okay. Thank you, Minister. And now, Deputy Chambers.
Thanks, Chair, and I'd like to thank everyone here. I know it's been a long morning for everybody. My first question, Minister, relates to this emerging field in general practice of online consultations. And there's been concerns from the Care Quality Commission in the UK about the I suppose, quality of prescriptions, the fact that opioids are being excessively prescribed, antibiotics as well, and the fact that there's no physical examination, obviously, with an online consultation. We're seeing these practices heavily advertised in an Irish context and a huge growth in that space. And the UK had found 4 in 10 were unsafe, or there were fears about their safety. So I actually raised in questions and promised legislation Minister Daly, I think, was in your place on that day. And I just want to know, what are your plans in that space around regulation, around guidelines, and around safety? And is the HSE commencing some type of audit or process to deal with this matter? That's my first question. I'm going to just I'll just see an answer on that, and then I'll come back. Yeah.
I might ask Dr. Colm Henry, as our Chief Clinical Officer, to update you in relation to that, if that's okay, Deputy Chairman.
Thank you, Deputy. With regard to online consultations, Deputy, I would see this as enhancing rather than replacing existing practice. Nothing can replace direct contact between a medical practitioner, a nurse, or an allied health care professional with a patient. But there are some examples of how we're putting this to good use. We have a virtual heart failure clinic which is now operating in the South East, which has replaced traditional referrals to consultants, which has actually resulted in 80% of people otherwise would have been sent to specialist consultation be dealt with through online consultation between GPs and consultants. And we have other examples of similarly online consultations, admittedly between primary care practitioners and secondary care practitioners, which again replaces people who otherwise would be referred to waiting lists, and to me is a much better investment in care. But the question you pertain to is how it pertains to direct engagement with patients. And as I say, my own opinion, that of clinical leads in our healthcare system, is we would see this as enhancing traditional consultation, meaning direct patient engagement, rather than replacing it, except in very defined circumstances.
You're not doing anything around similar to the Care Quality Commission. Are you doing? My question wasn't related to whether it exists or not. It was more to do with how are you developing guidelines around an emerging field of general practice, and it wasn't about whether it's good or not. I understand, obviously, with heart failure, but I mean, the flip side of that is someone who has chest pain. How do they triage that? So you know, if they've, how do you provide any, through an online consultation? So I'd just like to know how you're teasing that out as this emerges, like they've done in the UK. It's not a question of whether it's
clearly we haven't established, to my knowledge, Deputy, restrictive policies or procedures with regard to online consultation. And you referenced chest pain. Certainly, in the case of chest pain, there would be that would be a case where there can only be one form of engagement, and that's directly between the medical practitioner and the patient. So we'll come back to you with a fuller answer, certainly in response to the Care Quality Commission in the UK and how they're approaching it and how it applies to our healthcare system.
Yeah, no, I just think it's worthwhile if you did commence a process to provide certainty. And also, how does these are being heavily advertised across all radio and TV stations? How does that comply with advertising regulations around medicine generally? I know there's restrictions on that.
Well, I know there are restrictions placed by the Medical Council on how medical practitioners can advertise or not or their services. So I'm not aware. Again, if you bring these specific instances to my attention, Deputy, we'll certainly look into them.
We'll just listen to the radio. Yeah.
Just on that, Deputy Chambers, that's what Deputy Chambers is speaking about is unstructured consultations.
Yes.
I mean, we all understand the structured consultation between doctors or a specific clinic like heart failure or COPD or whatever, where there is a structured protocol in place. What almost Dr. Chambers, Deputy Chambers is speaking of is unstructured consultations, where the advertising, which is very well advertised on our airways at the moment, is unstructured care, where there is a problem, as outlined by Deputy Chambers.
Yeah, I think Deputy Chambers has raised an important point, which I think we need to take away, and both from a policy point of view, I'll ask the Chief Medical Officer in my department to advise me on it, and maybe from a delivery point of view, the Chief Clinical Officer, Dr. Henry, in the HSE, might take a look at it as well, and we'd revert back to you. I mean, it's an area that, quite frankly, hasn't been brought to my attention in terms of the need to do more in the area of regulation, but instinctively, I think you're onto an important issue, so I'll revert to you directly once I take advice from the CMO and the Chief.
Yeah, we don't need the Chief Justice sending us correspondence in 2 years about a patient safety incident because of a prescription that was sent by fax or by email. I think we need to be cognizant of that in a proactive way now. My next question relates to the just cervical check, and obviously Dr. Scally was before the committee, and both Dr. Scally and Dr. Denton said that it was unclear how the figure of 221 was arrived at, and the criteria for the selection. Did the 221 who were selected, did they all have cervical cancer?
Yeah, so we know now that some of them did not have cervical cancer. So just to be clear, the cervical check programme ran an audit, and it took notifications from hospital, early notifications from the hospitals of diagnosis of cervical cancer. Some of those ultimately transpired to be, we know in 2 cases, they did not involve cancer ultimately, which is a good thing obviously for those patients. And we know in 2 other cases at least where some of those patients did not have cervical cancer, they had another form of cancer. So the audit was taking the notification from the hospitals, running through the comparison then in relation to cytology, which is where we ended up with the difference between the original interpretation and the subsequent interpretation of the results. And then obviously the disclosure process fell down, as we know later, in terms of disclosing to patients. The second issue that emerged was that there were people then who had not been notified directly to cervical screening, who had been notified to the cancer registry, who were not included in the original audit. So the purpose of the Royal College of Obstetricians and Gynaecologists review is that it will look at all of the 3,100 women who were diagnosed with cervical cancer, and that is reducing down now in terms of around 1,800 people who would have had a screening history and also had cervical cancer, and they will form part of that review, which will give us the answers to some of the questions, I think, then that still arise around that.
So of the 221, there were 4 that didn't have, is that what you're saying?
So there are 4 that we're aware of from the original piece of work. So the Royal College review ultimately, and you would have missed probably a question earlier, Deputy, so the Royal College review, the purpose of that was to give the facts and figures in relation to, and give the patients certainty in terms of their audit results, in terms of reviewing their cervical cancer, was there or was there not an issue within it. The second thing it would do, it would give us facts in relation to the nature of the cancer that individual patients have had. What I mentioned earlier, in light of the fact that the consent rate from the group of 221 is relatively low, we are going to establish some of those facts now, and also given that will take some time. So we're gathering the information from the cancer registry and from the hospitals to make a definitive number around those that maybe did not have cancer ultimately or had a different form of cancer, etc. So we will close that out. But the Royal College review, as I say, was set up for that purpose, and that will look at the full women, the 3,100, around 1,800 that would have had the screening history, in terms of giving them clarity in terms of their cancer and any issues or not, as the case may be. Bearing in mind that close to 1,000 of those would have been diagnosed through the programme with cervical cancer, so that's obviously also a good thing. Around 1 woman every 2 days is diagnosed through cervical screening with cervical cancer, so we just need to balance that.
Yeah, okay. Just next question, I know it's been touched on by some of the others around the consultants who are appointed without completing specialist training. schemes, and Dr. Here, you mentioned that there's 50 that are pre-2008 and approximately 100, and you're doing site-to-site kind of visits. I mean, is there an issue here around the whole training programme as well, that you have consultants who would be perceived to be specialists but aren't in terms of their training, who are providing the supervision and the jurisdiction to other doctors who are within their training scheme? And I suppose, is there an issue around medical ethics as well, where you've got potentially a consultant, who's the lead clinician in a team, as I suppose, who's providing the end goal of care and of guidance around a patient plan, that they actually haven't completed their specialist training. It's also deceptive for patients that they believe someone is a consultant because they've completed the training. Obviously, they'll be on the general. I think Medical Practitioners Act is split into two. You've obviously general medical training, and you're on it for that, but also the specialist medical training. And there's a huge mismatch there around perception of skill sets. And if it was a plane, you wouldn't have a pilot flying a plane who hasn't matched the criteria for that. But in cases of specialist medicine in Ireland, we've allowed that. And aside from the personal training plans you're putting in place, who authorises these appointments, and who authorises, how did this? Have you done a look back about how this happened, and how people ended up as potentially locum consultants and then permanent consultants, and who was responsible for that and accountable for it as well?
Thank you, Chambers. Minister, or Dr. Henry?
Thank you, Deputy. Just very briefly, a brief background to this is specialist training schemes evolved and really came into play in the 1990s and the decade after. And by the time 2008 came in, it was a prerequisite, a requirement that you had to have completed a specialist training scheme in order to be certified as a specialist. Before 2008, that wasn't the case. It was an accrual of experience that was reflected in your CV and your references, and I suppose the interview process and what came after. So since 2008, it's a requirement to be an interview to be on the specialist register. And as I said earlier, in looking at our cohort that we're dealing with, 50 or so of the consultants are pre-2008, who since then have been working as consultants in our healthcare system and have accrued experience, knowledge and expertise while working, not just in a training part of their careers. And we have about 100 after, divided between psychiatrists and hospital consultants. So in terms of you're asking your question, deputies, how did this come about? Is in answer to a question earlier, I stated that we have 29 emergency departments in this country. We have 19 maternity units and paediatric units, and in all those hospitals we have unscheduled care services, be they emergency departments, obstetrics, paediatrics, anaesthesia, surgery, medicine, that requires somebody there all the time. This isn't an excuse, I'm just stating a fact that there's an obligation for us to continue unbroken those services. And in some cases, my own assessment is, and that based on our own HR department, is appointments were made because they simply couldn't find anybody else with the necessary qualifications and training scheme completion to perform the same post. But what we are doing is mapping through and going through each of those individual cases, developing personal plans for each one to see if first of all, if their existing qualifications, their existing working experience qualifies them to be on the specialist register, and if not, what the gap is and what additional training or supervision or mentoring is required.
Thank you. Dr. Henry.
Just
finally,
yeah, please. Just two last questions. So one of them relates to pay quality for consultants, and what are your plans around that, Minister? And obviously, there's a huge mismatch now in light of the recent case, and in many cases, people who would apply for contracts are seeing a huge pay gap. Are you looking at a pathway to bridging that gap, or are you looking at a new consultant contract? And have you discussed if either of those, is it pay quality or is it a new contract? And then I just want to finally ask about just quick update on hospital trust legislation. It's been in the ether for a long time, and obviously there are boards of hospital trusts that have no legislative oversight, appointments occurring without without any clarity, in my view. And I'd like to know what's the update on that. And then just the final run of questions. And then just in terms of the NTPF, what's the process of say tendering for NTPF work? There's a lot of say public hospitals now that are doing NTPF work, say on a Saturday. And what's the governance criteria if, say, a public consultant, are they getting paid in addition to their own public contract for NTPF work that they do in a public hospital? And how is that audited? Like, could there be a perverse incentive for somebody who has large waiting lists to control those waiting lists around the whole NTPF process in public hospitals? And what's the governance criteria for that?
Thank you, Deputy Chambers. 3 questions in one.
Very good. Thanks, Deputy Chambers. In relation to new entrants, I discussed this earlier with colleagues here. I mean, my view is, and it's not just my view actually, it's the view of the Public Service Pay Commission's report, is that there is an issue, obviously, when it comes to recruiting consultants, and that it also did note in that report that reductions in the pay of new entrants appointed since 2012 was particularly severe, but that also the differential had obviously, as you've implied, worsened as a result of settling or negotiating a settlement to the consultant contract cases as we did earlier in the year. So it is my preference that we would enter a process, as we have done with others in the public service, to look at how do you address the issue of new entrant pay. That obviously is a discussion I'm having across government, but I do believe a process as outlined in the Public Service Pay Commission would be welcome. I don't see that directly linked to the broader conversations that we're going to have about consultants, launch of care and contractual reform into the future. That's my sense.
Is there a plan for new contractual space? Are you going
there is, but it's not. We're not there yet, quite frankly, because it's very much tied in with launch of care. So we'll publish the first launch of care action plan around Christmas time. We'll bring it to Cabinet in December, and that will obviously outline the actions we're going to take then. It's a huge body of work that the Sláinte Care team need to do in taking the Sláinte Care report and working out what are the contractual implications of this for lots of different healthcare professionals, of which consultants will be one group, but we're not there yet in terms of being ready, quite frankly, to have that conversation in terms of what the consultant role of the future looks like. We'll also be very much informed by the Donnelly to Butler group as well, which is obviously, as you know, been established to look at how do you decouple private practice in public hospitals, which is something I feel very strongly about. There's different views on it. I don't think it's appropriate that private practice is happening in public hospitals. I don't have an issue with private practice, and I don't have an issue with people doing private practice, and whether there's a choice of playing golf or doing private practice, it's not my business, but it's doing the private practice in the public hospital that irks me, and that's what I'm hoping the Donnelly to Butler group can help us with. On the hospital groups, so firstly, I'm not sure you meant this, but just when you suggested appointments kind of happening without clarity, I mean, so anybody appointed to a hospital group, those appointments have all gone through the Public Appointment Service. I populated all of those boards in recent months, and they all went through the Public Appointment Service. But you are, of course, right that they only exist in an administrative capacity at the moment. They don't have a basis in law. I have taken the decision, when Sláinte Care was published, not to push ahead with legislating for the hospital groups for 2 reasons. One, I'm not sure I commanded all majority to do it, quite frankly. And 2, Sláinte Care has moved us to a different space, because Sláinte Care rightly talks about these integrated care entities, whereby you'd have your CHOs and your groups effectively over time aligned, and that you'd legislate for that. So I will be bringing forward proposals on geo-alignment in the coming months, and then I would move forward to legislate for those bodies, rather than legislating for hospital groups and then having to come back and do it again.
So is there kind of a temporary fix then?
So yeah, I mean, the hospital groups, look, I mean, accepting a cross-party vision on healthcare does mean doing some things differently to how you were planning on doing them. And the idea of legislating for hospital groups now would ignore the fact that the Sláinte Care Committee has quite rightly said you'd be better off legislating for regional structures that include community health organisations, one entity, no siloed approach to it. So that's the direction of travel I intend to take. On the issue of the NTPF and how it ensures that it complies with all its various obligations under procurement and governance, I'd be happy to get you a note from the NTPF on it, but I am satisfied that the NTPF concentrates on additionality as opposed to paying somebody to do something.
No, my query was say a hospital's running.
Sorry, Deputy.
I'm finished. I'm finished. I accept.
To bring in Senator Conway Walsh.
My point was that say hospitals running over budget.
Sure.
They're not meeting the capacity and the target set by management, and they're getting an additional amount when they're not meeting the output within their existing requirements through the NTPF. I don't think it's a prudent way to be apportioning lots of resource that we have, but that's my point. It's more how, I wouldn't like to see ineffective, inefficient, frontline, allocations occurring where they're not meeting the output that might have been planned for them, and that was my concern.
I think, Chairman, and I'll stop talking too on this. I think it is an important point. I mean, I am confident though that the NTPF does focus on making sure that the work it's paying for is work above and beyond what was due to be done by the HSE, and that we publish integrated waiting list plans. What's the HSE going to do for this year? What's the NTPF going to do for this year? But I will send the transcript of your question to the CEO of the NTPF and get you a note back in relation to that.
Minister, thank you very much. And finally, Senator Rose Conway Walsh, thank you for your patience.
Thank you, Cathaoirleach. And I have a number of specific questions, but I suppose the first one is in light of what the service that Maurice McCabe has done in highlighting the need for whistleblowers, but also in giving us, I think, a clear example as what can happen to whistleblowers within a system. I think it's very important that you make a strong statement, Minister, in relation to the health service, because we have all this anecdotal information, and information, actually it's first-hand information in terms of when people make a complaint and when people within the system make a complaint. And it could be a complaint about their working environment or the unsafe environment that they're being made to work in. And I know directly of where I've been told, they've been told, well, there's the door. If you don't like it, that's it. So what could you say that, you have your service, your say, and you have different practices, but they don't really work in the way that we need them to work, to encourage people to come forward, to make our health system safer. So what could you say, Minister, that would guarantee people that if they're working in an environment today within the health service that they think is unsafe, or they see somebody else's practices that are threatening the health and safety of either the people they're treating or those around them, what could you say?
So first thing I'd say is I think you're right to suggest that there's learnings for the public service beyond just in Garda Síochána in terms of how it responds to whistleblowers and how it responds to people trying to highlight real areas of either wrongdoing or public concern. And I think we obviously saw that in a very vivid, very vivid way in the Katie Hannon documentary with Maurice and Lorraine McKay, which I thought was excellent. What I would say very simply to anybody working in the health service is, though, that our laws have now changed and that we have protected disclosure legislation. And I know as the Health Minister, I receive protected disclosures. I know that the HSE has a protected disclosure policy in a system. So the law of the land is that your service, your say, is a way that people can make complaints, absolutely. But in terms of bringing issues to the attention in a protected space that protects whistleblowers, the law is very much on your side. I think the law is working. And I think we've seen examples already of how protected disclosures can bring important information to the authorities' attention. So I would encourage anybody working in the health service, or indeed anybody using our health service who wants to highlight any matter from a whistleblowing point of view, to use the laws that we have passed in recent years to protect them.
Okay, and can you assure them that if somebody makes their job impossible, should they come forward and make a complaint, that that person will be severely reprimanded?
I mean, I can assure them that the law of the land will be complied with in terms of the protection afforded to whistleblowers.
Okay. The other thing, I suppose, in terms of the number of misdiagnoses there has been and the number of mistakes and that, what provision has been made this year for people seeking redress?
I don't quite understand the question. There is no redress scheme.
I'll tell you what it is, Minister. I'm just trying to quantify the problem of misdiagnosis or where mistakes are made, and either in terms of numbers that have been referred to the state claims agencies or numbers of people. I think we need to quantify what's happening in terms of...
Sure, sorry, it was the word redress that threw me. But so we've made an allocation for the State Claims Agency for 2019, which Mr Mulvaney might pull out for us there, but I must make the point that obviously that's not a figure all related to misdiagnosis. It's a figure related to any actions that is taken by any citizen against the state, and obviously the power for dealing with them is delegated from the HSE to the State Claims Agency. Do you have the figure for allocation?
It's in excess of 300 million by the end of this year.
In excess of 300 million. Okay.
We'll get the exact figure.
If you could, maybe, and let the committee have it. I have a case of where obviously a file was missed, of a file saying needs urgent attention, and 12 months later the woman is terminally ill and there's nothing that can be done for her now. How long should it be before her family can get the file, get the full file in relation to her case?
What I'm not going to do here, though, is start adjudicating or sensing to adjudicate on what you're putting forward, and I don't in any way question your bona fides.
Okay.
But if somebody, your fundamental question is asking, can somebody get basic information about their medical information from a hospital?
Their full file. So somebody requests their full file today. How long should it take before that file is available to them or to their family?
I'm going to look at Mr McCallion and Anna Connor for this, but I think there's a standard. Is it a 30-day turnaround?
Yeah, for access to records to a service. I think that's, I'd have to just confirm it, but I think it's of that order, yeah. So in other words, if a patient requests the record from a hospital or from a health service, that they can get it within that time frame, where it can sometimes be complex, and this is where there's sometimes a discussion with the patient or maybe with a legal representative if there's a legal case. If there's a multitude of services involved, maybe a hospital, a mental health service, it could be a variety. But I believe it is 30 days in terms of access to records, yeah. We can confirm that.
I should also say that under the Justice Meanin recommendations in terms of redress, I think that has been reduced to 21 days. Yep.
So after 21 days, the family should be able to get the file. And if it's
28 days, pardon, 28 days, I've just found it. Okay, so this is under the Justice Meanin review, a requirement for records to be supplied within 28 days.
I think that's a specific requirement as well, John. So I think in terms of the broader requirement, which I think is the point about access to records in a hospital or in a particular health service, I believe it's 30 days, but we've maybe confirmed that with you this afternoon.
Okay. And if somebody doesn't get their file after that length of time, where do they go to? Say they requested from the particular hospital, where do they go to?
There are people in each of the hospitals designated to deal and responsible for ensuring those requests are dealt with. There may be instances where the nature of the records, they're moved off-site, they're historical, just know from a former role in terms of practical experience. So in those instances, they should actually proactively engage with the patient, have that discussion or with their representative to ensure that they can set a time frame on that. So the patient, there is an escalation within the hospital initially for that patient, should they be unhappy with that in terms of getting access to the records.
And if the patient dies in the meantime, while they're waiting for the
next
file?
of kin, for example, in a tragic circumstance like that, then the next of kin would be entitled to follow that through.
To automatically, they wouldn't have to go over the process again.
We'll confirm that, which I'm not an expert in that, but that's broadly speaking how it operates. Yeah.
Okay.
Total budget available to the HSE this year to reimburse the State Claims Agency is 320 million.
320, okay. That could be spent in the health service. Now, I just want to ask you about Valparaiso again and their rationale. I have to say as well, the questions, and Cahir, look, we only got the answers to the questions this morning that we had submitted, which make things very difficult, because in terms then of checking back the accuracy of the answers that we're getting, it makes it difficult. If we could have the answers even a couple of days before the committee, it would be really helpful with our engagement with the people who are most impacted by the questions that we're asking. But I want to ask you around the Valparaiso situation. I want to ask you particularly, I thank you for the written answer that's been given here, but the study that was mentioned in your letter to the Facts Forum Ireland, of which Oaks Ireland is a stakeholder, is like a rapid assessment report to estimate the numbers affected in Ireland, and this is based on the Irish data combined with the international statistics. What I'm concerned about is that it won't address any of the historical issues, just kind of the effectiveness of the risk minimisation. And this is why I think it's really important that we have a proper independent inquiry into this. There are an awful lot of questions still outstanding, Minister, and I see what you're trying to do in terms of, looking at the different elements of this. But the fact is that we need to know who knew you know, who knew at what time the impact that valproate would have on pregnant women and on the children that they were going to give birth to. You know, it was the Minister for Health in 1975 and the IMB, the Irish Medicines Board, now HPRA, who licensed it. And why for years were they telling us that it was licensed in 1983? So there's just an awful lot of to be cleared up there, and I feel it can't be cleared up without an inquiry. And I think, you know, now this isn't particular to Ireland, as you know, but a lot of the people who are impacted by this are now finding that they're having to go to Britain to get more information on it. You'll know as well that a redress scheme was set up in France for it. So the same mistakes were being made in all of these countries. But I really think we owe it to these families who, you know, are trying to do their best for the children that they have brought up with disabilities in it. So can you just speak to that, please?
Well, I'm Henry to say a word in a moment, but just briefly, because I know you've saved some of this in the written answer, but if anyone's watching these proceedings, they don't have the benefit of that.
Yeah.
So, I mean, there are a number of work streams underway in relation to the issue of valproate, and I had an excellent meeting with Facts Forum Ireland, where they outlined to me the very devastating consequences that this had had on their own lives and indeed that of their children, and the difficulties that had posed in rearing children in very difficult circumstances as well. So we have, obviously, firstly, in terms of protection now, we have the Health Products Regulatory Authority has done a huge body of work in terms of reviewing the information provided.
Yeah, that's off the table. I do welcome that very much. That was
so I do think that's good
for.
in terms of patient leaflets. It took a lot of work, I think you're right, and that's good, and I know that's been shared with representatives of Facts Forum. We have the Valproate Response Project, which is looking at proposals for the study of the numbers affected by facts, which is the point you're referencing, and the development of the existing Irish Epilepsy and Pregnancy Register. And the Royal College of Surgeons, in collaboration with the HPRA, will be conducting an impact assessment project on the effectiveness of risk minimisation measures to prevent harms from such medicines, including sodium valproate. So that bit's underway. And the HSE is also currently gathering information on sodium valproate through the Patient Support Service. One of the issues I want to try and do, and I did give a commitment to Facts Forum when I met them, was that they would have a contact point within the health service for the many and disparate needs of some of their children, because they did talk to me about how they felt being bounced from Billy to Jack, to use a colloquial phrase, in terms of trying to identify the services. And I know there's work going on with the Children's Hospital Group in that regard. To be clear, I hadn't ruled out an independent inquiry as other countries have done, but I remain to be convinced it's the best way to get them the information that they rightly need and that they deserve. So what I did want to do was get all of these work streams to report first and then make that decision. But before you come back in, can I maybe just ask Dr. Henry to bring us up to date from his perspective?
Thank you, Deputy, for your very apt question. Valproate, is fair to point out, is a very effective drug in many circumstances.
I know.
And there has been always an awareness of this teratogenic or effect in utero. But what's happened in recent years has been a growing awareness, not just in terms of the impact of the drug, but the frequency with which children can be affected. So our priority as the information became more available to us through Europe and through other healthcare systems was to address the immediate safety need of making sure that all women of childbearing age were made aware of the risk of this drug. And equally, we wanted to be sure that nobody stopped the drug abruptly, because that could lead to harm in itself to people who, for example, had well-controlled epilepsy. So the work we've been doing throughout the summer, and I want to pay tribute not just to my own team who've been working on this, but also to the patient representatives from the Facts Forum who've been contributed hugely to this work, is we've communicated with 2,500 women of childbearing age who've been on the drug. Firstly,
and I know, I really do appreciate it, and I commend the work that has been done, absolutely, without a doubt. And the organisations that have worked with you to do this, I commend it. But I do think there is, we need to know what happened, why did it happen, and why was it let continue, and who knew. And we need a redress system in place similar to what's in place in France. And I know the good things, but I'm just really conscious of the time, because I have a couple of other questions that have been done.
I can't answer the question with inquiry, but I can say that, as with other anticonvulsant medication, there always was an awareness, or a change with increasing evidence over the years, was the impact and frequency that this drug had in terms of its effect on children.
Okay, but it wasn't there wasn't an awareness of the patient, of the woman who was taking the drug. There wasn't an awareness, and that's the problem. So where was the awareness, and why wasn't the awareness put on the packages so that the woman could make the decision, or her GP could make the decision, or maybe her GP knew? I don't know, and it's those kind of things that we need to find out. So I would ask you, I am glad, Minister, that you haven't ruled out an inquiry into it, but I would ask that we take the learning from France and Britain as well, and that we get this cleared up, and that we get full accountability for what happened. I think it's the least that we owe to these families. I need to
know, Senator, we have to vacate the room in by 13:45 at the latest.
Okay. I need to ask you about Translarna. And again, I'm kind of completely up to date in that, in terms of, but I want to know, when is the decision being made? That's the drug, obviously, for the muscular Duchenne patients, Duchenne muscular dystrophy patients.
Okay. So I can just give you a bit of information on that. So we now have a new application lodged from the pharmaceutical company. Okay.
Yes, I
we have a lot of historical work already done through the clinical clinical advisory group and the drugs group on that. So there's intention to take a look at that on a fast-track basis. Okay.
So when?
So when?
When will the decision be made?
I can't give you that just now. I wouldn't want to guess on that, but I am assured that, given all the work that's been done previously on that, okay, that we will attempt to move this through the system very fast. What I can do is I may give you an indicative timescale, but I'll write to you on that.
Please, because you know we still have the 5 boys, and it's only the 5 boys, and they are in a very difficult situation. So I really hope that progress has been made with the second application, you know, that was made, and I am want to welcome the fact that the legal case was taken off the table in order to facilitate this happening. So I hope that we'll have a positive result there. I have to ask you about Spinraza as well. And just to ask you, do you know that some of those sufferers, the SMA ones, have been hospitalised and have been in intensive care waiting for the decision on Spinraza? When can we expect that?
Yes, so I am very much aware. I am very much aware of this case. It is obviously a matter for the HSE to follow its own reimbursement processes legally in this regard. But I did meet the HSE on a number of issues recently. This was one of the issues that I specifically raised with them. I think it is really important that there's real and meaningful engagement here with the drugs company and the HSE. And I know that the Technology Review Group on Rare Diseases is currently working its way through the application. It will then go to the HSE leadership team shortly for a decision as well. So I know this is an issue of significant concern to a number of parents across our country. So it's currently with the Technology Review Group on Rare Diseases. Will then go from there to the HSE leadership team.
Can I just ask you, is that review group, are they updated in terms of, say, the children's conditions, or children who have been hospitalised or in intensive care who are really seriously ill? Do they take that into account in terms of their decision-making process?
They're there to assess the drug and the impact of the drug, but specifically under the idea they were established, I suppose, recognising that there are rare diseases that require greater consideration perhaps than a drug that could benefit maybe a larger cohort of the population, that there are more and more rare diseases in Ireland that new drugs are coming on stream for. But I do need to make the point that it takes two to negotiate. And I do want to make that point strongly. And it's right and proper, absolutely right and proper, Senator, that in this forum you'd apply pressure to myself and the HSE. That's your job to do that. But I would encourage similar pressure to be applied to drug companies as well, because they have the drug. They have the drug that parents believe could make a very big difference to their children's lives. And I do hope if the drug company and the HSE could engage in a very meaningful manner on this, we can try and make progress.
I do think it's very important as well that there's proper negotiation around the price at a very early stage, so that we get the price as it is, not multiples of the price and then trying to make decisions on that. I think is a bit crazy. And I just want to finally ask you around the audiology failures in Mayo and Roscommon. Now, I know a number of things have been done around that, but again, we are at a situation of we don't know who was responsible, if the governance was put in place for it. And there's also difficulties coming. You've presented me with a long written answer here around what has happened in terms of the Department of Health, of medical cards, around employment affairs and social protection, around education and skills and that. And there are still shortfalls there within that. So I would ask you, I'm hoping that this committee may take hearings in the new year to hear the impact that audiology failure has had on the families involved. And we need to get to the bottom of it. You know, is that governance, and why wasn't that governance in place? Is it in place now? Sure. Could it ever happen again? And why did it happen in the first place? I mean, at the end of the day, there's 49 children.
I'm going to ask Anne O'Connor to respond to that from the HSE's perspective, but just to say briefly, I had an excellent meeting with some of the parents whose children had been impacted in government buildings recently. There were also Chief Officer Tony Canavan was present from the HSE, as too was a senior official from the Department of Social Protection. A number of undertakings were given at that meeting in terms of trying to provide support to the children who had been impacted. And I suppose what was very clear at that meeting, and very clear in your own outline today, is that not all of the supports required were health related. That there were some specifically in the education space that seems to be a particular sticking point at that meeting. So there was a commitment given that officials would meet and that they would then re-engage with that parents group. So I hope and expect that's happening. And if you hear anything to the contrary, please let me know. But from the governance point of view, Anne, you might just...
Yeah, no, I think, so the review that identified the errors and failures, that was on a review of standards that had changed. So there is now a National Clinical Audiology Lead. So the governance has changed since that took place. I mean, just to confirm as well, the meeting happened on the 5th of November between the different officials. So there is a robust governance structure in place, and certainly the learning from that incident, and it happened in another part of the country as well, have absolutely been examined. And in terms of the audiology programme, we would hope that that wouldn't happen again.
Thank you very much.
I'll let you know of the gaps in between.
Thank you, Deputy or Senator. Thank you very much. So, on behalf of the committee, Minister, thank you for coming. We understand your delay. Thank you, Mr. Breslin, Secretary General, Mr. Connaughton, Mr. Mulvaney, Ms. O'Connor, Damien McCallion, and Dr. Henry. Thank you very much. As this is the end of our business, the meeting will be adjourned until Wednesday, the 21st of November at 9 a.m. Is that agreed? Thank you.